Now. Hey, David.
Hello.
All right.
Looks like we are still waiting for Supervisor Chavez and Supervisor Simidian to log it back in. Oh, there's Supervisor Chavez.
There we go.
And there is Supervisor Simidian.
There's my video.
Recording in progress.
Boom. Let's do a roll call to reestablish the presence of a quorum.
Good afternoon, Supervisor Lee.
Good afternoon, Lee. Aye.
Supervisor Chavez.
Here.
Supervisor Simidian. You're muted, sir. Here. Thank you. Vice President Ellenberg
I'm here.
and President Wasserman.
Here as well. Thank you, Mr. Leon. We now turn to item number 10 in today's agenda. Receive report from the Public Health Officer and administration relating to the current status of COVID-19. We look for our fearless leader, Dr. Cody. I see Rhonda on my screen.
Good afternoon, Supervisor Wasserman. This is Sarah Cody here for your COVID and other respiratory virus report. And we'll get the slides up in just a moment.
We're ready.
You're faster than we are.
There you go.
Almost there. Okay. So the first slide, I'll just start out as I always do with the case counts over time, our epidemic curve. And if you just looked at this, you'd say, wow, we're in really great shape. Just a little uptick there over on the right, but doesn't look too bad. However, if you go to the next slide, these are our wastewater concentrations. So it's the level of the SARS-CoV-2 virus in all 4 sewer sheds. And as you remember, this covers pretty much the whole population of the county. And what I want you to note is just a couple things. One, whoops, back one slide. They are, the levels are high in all 4 sewer sheds. They're going up very steeply, that's important. And in some sewer sheds, Palo Alto and Sunnyvale, they actually, the levels of virus have exceeded their peak during Omicron. So
Wow.
more virus circulating in the Palo Alto sewer shed than during the highest peak during the Omicron surge. And same goes for Sunnyvale, with Gilroy and San Jose right behind. The San Jose sewer shed is really important because it covers about 75% of the population in our county. So if you just wanted to look at one sewer shed to give an idea about how much COVID is circulating, that's the one you'd look at, and that's the orange line. So the next slide just shows these two things together. The red line as the concentration, this is just the San Jose sewer shed, the concentration of the San Jose sewer shed as compared to the cases reported from that sewer shed. And you can see that those lines diverge quite a bit. So what we really need to be looking at this point is the concentrations in the sewer shed, and the case counts really don't mean much. And as far as what's driving that uptick, it's what I would sort of call a variant soup at this point. There's no one dominant variant that's creating the surge. Rather, it's a mixture of them. And the next slide is how this is translating to hospitalizations. And these are people hospitalized with COVID, not for COVID, but the proportion of with and for has stayed pretty constant over time. And what I really want you to notice is way over there on the right, how steep that is, that's going up very fast. And I'll share a little bit about influenza later, but what I want you to know is that it's not just COVID that we're worrying about right now, it's COVID and influenza that are impacting our hospitals. And across the state, and I think in the county, it's about half and half. Hospitalizations for flu and hospitalizations for COVID. Plus, of course, all the other reasons that people are hospitalized. And the next slide are the lab confirmed deaths by week in the county. And of course, we're not yet seeing the COVID activity right now reflected in deaths. But I imagine that we will. And one reason is because, as I'll share in a little bit, we've not had the uptake of the bivalent booster that we would like to see. And the next slide shows that this is the uptake of eligible people who've gotten the bivalent booster by age group. So the good news is that among people who are older, 50 and up, and certainly 75 and up, higher percent of eligible have been boosted, but overall, only about 25% who are eligible have been boosted. So this is concerning, particularly those over 50, where we'd certainly like to see those booster rates north of 80%. And the reason why it's worrisome, not just for the people who haven't been boosted and don't have protection for themselves, but how it might translate to further impact on our already strained healthcare system. Next slide. So I'm just going to give you a very quick update on respiratory syncytial virus. The best data that we have actually are the wastewater trends, which you can see here. And we have a little glimmer of good news, which is that it's beginning to kind of plateau. And there's some other early signs that it's beginning to plateau. Hasn't quite translated to easing of the pediatric hospitals, but we certainly hope that it may do so soon. And then as far as flu, this is a slide, an update of a slide that I showed you before. These are, it's a year's time, kind of an October to September, and each flu season is represented in a different color. So this year's flu season has just gotten underway, and that's in red. And they're shown like this so that you can see these are influenza-like illness reports in the county. And you can see that we've got a very early and brisk start this year. And so the influenza-like illness among people seeking care in the emergency department is well above what it usually is for this time of year. And it's very, very, very unusual to see this already in early December. Next slide breaks out for you just a little bit about who is coming to the emergency department for influenza-like illness. And you can see that the 0 to 4-year-olds, which are in the blue, have the highest percentage of emergency department visits, followed by the 5 to 17-year-olds who are in purple. And again, this is at sort of a symptomatic definition of influenza-like illness. Some may be influenza and some may be other respiratory viruses, but it's really to give a sense of trend and magnitude. And then another way to look at influenza is in the wastewater. These are the levels of influenza A, just influenza A, not influenza A and B, across the forest sewer shed. And you can see that it's been significantly increasing across all 4 plants since the end of October, which is when we started measuring it. And finally, the next slide, I just wanted to share that we have a influenza dashboard. So this is just a little snapshot from the dashboard, mostly to let the board and the public know that they can follow the influenza season on the dashboard. And there are various types of data there, wastewater, influenza-like illness, ICU impact, and a little bit about what kinds of influenza are circulating. So this is where the public can go to understand what's going on. And finally, I don't have slides on this, but I just wanted to talk a little bit about the impact on our hospitals across the county. It's been an early and active season, and I know the last 2 winters, of course, have been enormously challenging because of COVID. And this year, it's, the first year we were challenged because we didn't have a COVID vaccine. The second year we were challenged because we had Omicron with a lot of vaccine escape and just so much transmission and so much infection. And this year we're challenged because we have not just COVID, but we also have influenza, RSV, and many other respiratory viruses. And all of that is conspired to really stress the hospitals. Many hospitals in our county are running close to full capacity, and it's only early December. And so I think my plea is for everyone who can get boosted to get boosted. That will help ease things a bit. Everyone who's not gotten a flu shot, please get your flu shot. And whenever possible, although masks, of course, are not mandated, but indoors, it's not really a safe place anymore, especially if it's crowded and there's a lot of people without masks. And that's a really good time to choose to wear a mask. And I'm happy to answer any questions that you may have.
Thank you very much. I'm happy to say all the above shots my wife and I have. All right, I don't see any hands raised from, now I have 1. Now I have 3. This is good. All right, Supervisor Chavez first, then Supervisor Smitty, and then Supervisor Lee.
Thank you so much, and thank you for the report and the work. And I wondered if you could go back to the impacts to the hospitals, and just share a little bit about what the implications are of obviously flu and RSV and also COVID as it relates to what you're seeing in the wastewater. And what's curious to me is the high number in the wastewater, but it doesn't seem to be corresponding with what we're seeing in the hospitals.
Right. So usually we would see a first signal in the wastewater, then we would see a signal in case counts, then a signal in the hospitals, and then a signal in deaths. So now we're seeing wastewater and then lag and then hospitals, because not much is happening in the case counts because people are testing at home with antigen tests.
Mm-hmm.
So if you look at the hospitalizations, it's way on the far right that you're beginning to see an uptick in COVID. But it's not just COVID that's impacting the hospitals, it's influenza. And I'm sorry, we don't have data on influenza hospitalizations. I'd asked our team if they could put that together so you could see. But general rule of thumb is there's about as much COVID as there is flu. So if you're thinking about the overall impact of hospitals, you would look at that uptick in COVID, and then you would sort of double that, and you would see, that's the about the impact of patients in the hospital needing some kind of care who have a respiratory infection. So it's a little fuzzy, but it's again, the difference this year is that it's a combination of many different respiratory viruses that are landing people in the hospital. So if you just look at the COVID data, you're not going to fully see the picture.
So understanding that, I guess when I'm having a hard time, and maybe this exists somewhere and we just don't have access to it, I don't understand the how to assess these multiple threats to the healthcare system relative both to ours and other systems, because I don't know where we're at capacity with which part of our healthcare system, meaning emergency rooms, ICUs, maybe just general bed usage.
It's throughout the healthcare system. So I'll give you a couple of examples. In outpatient pediatrics in many different systems, ours included, has been significantly impacted because there's so many children coming in with RSV or flu or COVID. Similarly, pediatric beds, both regular beds and acute care beds, are really strained in our county. And not every hospital has pediatric beds. But those who have pediatric beds, those pediatric beds have been mostly full, and sometimes even with patients in the emergency department waiting for a bed. The EMS system is running faster than they usually run, with more runs than they usually run. So my point is, you can see it throughout the system, from outpatient to ICU and everywhere in between.
So understanding that, what I'm requesting from staff for next Tuesday's meeting is actually a visual that explains that. I think we need to be able to share with the public as concretely as we can. Here's what the capacity is normally. Here's what it looks like right now. Here's what it's going to look like. And I think that's part of us being able to educate people about their flu shots, about making sure they're getting the bivalent, and what, if any, protections people have, I think, relative to RSV. And I also think that we went from explaining to everybody to wipe everything down to, you don't need to wipe everything down. This is more of a, an aerosolized illness, to now we're telling people to wipe everything down because of the RSV. So I would like something that we could share with the public that helps them understand the concern. Both, by the way, I think the point you raise about the healthcare on the hospital side is really critical. I think the point you're raising on the EMS side is really critical, because my next question is, what actions are we taking to prepare for the needed, potential needed expansion? Again, which, if we're not prepared to talk about that today, by next Tuesday, I'd be very interested in having that explained, so that, again, the public understands what actions are in need. I think we have, obviously, let me just say, I apologize for stating the obvious about the fatigue that the community has, but I think for those who are thinking about how to protect themselves and their families, this kind of information is actually very helpful.
Yeah, well, if I'm sorry I don't have a picture, I can, and we'll see what we can think of. But I guess I'm telling you right now that the hospitals are meeting at least weekly, and even more broadly as a region, particularly for pediatrics. EMS is meeting with the hospitals, public health is meeting with the hospitals. Many hospitals are managing surge within their hospital. So all the things that hospitals do to accommodate an influx are already happening. Emergency departments are already full.
So Dr. Smith and I did a communication around flu shots prior to Thanksgiving. And one of the questions that we got over and over again from the press was, help us understand the implications. And they were asking a lot of questions about numbers, which is, what's our normal capacity? Where are we at now? What are the implications of it? I think all of that is what I'm asking for. And I don't just mean a picture. The reason I was using that is that I was actually thinking about something that would be easy to convey both to the public and to the press. So but I understand the point you're raising, which is we're heading into some choppy seas. I just think we have to be thinking about how to make sure that our partners can help us communicate that effectively in the public and give people options for what they can do to address it. I've sent people back to our website as an example to make appointments and all of that, because it's almost like we have to refresh the skill of what people could do to respond to this next surge or the current surge. Thank you.
Thank
Thank
you.
you. Supervisor Simitian?
Thank you. Dr. Cody, I am, of course, concerned about the North County spike, the Palo Alto sewer shed, and wanted to ask first, can you tell us or some member of your team, can you tell us what communities rather, are part of that sewer shed?
The website with the sewer shed information actually describes which communities are served by which sewer shed.
Okay.
I believe it's Palo Alto, Los Altos, and there's actually part of San Mateo County. East Palo Alto is also served by that sewer shed. It's one of the smaller sewer sheds.
Yeah. Any notion as to why that might be the spiking the way it is?
No, other than the Thanksgiving holidays served as something of an amplification event, as it has for the last 2 years, where more people are gathering, and there's more transmission, and that's reflected in the sewer shed. As to why Palo Alto would have higher levels at the moment than others, I don't know. We started seeing that pattern actually with Omicron, and it's persisted.
So we don't really have a handle on why the numbers are dramatically worse there than they would be in the other 3 sewer sheds?
No, I don't. I don't have a good explanation as to why that would be. That being said, the actions that we recommend people take are the same. They don't vary by sewer shed.
Yeah, but we're getting a different result and not a good one. That's an outlier. So telling everybody to do the same thing, if one place is getting a different and worse result, it gives me pause, as you can imagine. Let me ask
Supervisor, let me give you the number or the names for the Palo Alto sewer shed. It includes Los Altos Hills, Mountain View, Palo Alto, Stanford, and East Palo Alto Sanitary District.
okay. And if I could ask to go back to the I think it's the second or third slide that shows that green line popping off the top on the right side.
Just a second. The second or third slide.
We can go to the next slide, please.
I think it's actually back.
Is it back one? Forgive me.
Yeah, I think it's back one. It's prior to the hospitalizations.
There we go.
And that one or back one more?
Back one more. There we go.
There you go.
And you can see that green line on the right that is easy to spot. And now it just disappeared on my screen. Somebody was enlarging there. Well, not quite. Now we need to go a little to the right. There. And now down a little so we can see just how far up it goes. A little tour. Is this Dr. Smith working out of classification again? Is that what we got going on?
Yes, it is.
Well, just go back to the basic shot. If you could please. There you go. Dr. Cody, I'm guessing people's ears picked up when you said that number is the highest it's been during the almost 3 years now that we've been dealing, or that level is the highest it's been during 3 years. And as we can see from looking at the chart, it's clearly higher than these last 2 bumps that we've had. Am I hearing that right?
Yes, the levels of virus concentration in the Palo Alto sewer shed is higher than it's ever been since we started measuring during the pandemic. And this is actually a nice view for you to see that prior to the Omicron surge, that was, if you compared the 4 sewer sheds, the Palo Alto sewer shed didn't display the highest concentrations.
Right.
But since the Omicron surge, it peaked higher than any other sewer shed and has remained a bit above the others for most of that period. But you can certainly see for the majority of the summer, levels were higher. And I can't explain it. I don't know exactly why that is, but something in the virus, the dynamics are a bit different.
Well, part of the reason so let me then ask, do we have, I'm guessing we do, and forgive me if it's on the website, I haven't looked recently, but do we have booster rates by city or by supervisorial district?
We don't have the booster rates on the website, but what I can tell you, we every now and then we look at the data by region in the county, and the booster uptake by region, those patterns for the Omicron booster are very similar to the patterns for the first booster and the second booster. And what they generally show is that North County and West County have higher booster uptake as compared to East San Jose and South County, which generally have lower intake. So that doesn't really match with what you're seeing as far as the concentrations in the sewer shed. But I think it to me, it underscores the point that the boosters are extremely effective in keeping you out of the hospital. They are less effective in keeping you from being infected and from being able to transmit to somebody else, which is why, unfortunately, the layers of protection, including mask wearing, is still really important. And I know it's been 3 years and we're all really tired of it. However, the vaccines are not, quote, sterilizing, and so we need other layers.
Yeah, I get, you're being very gracious and professional. I mean, I get that the vaccine doesn't care if we're tired of it. I understand the thinking there, but now I really am even more perplexed because you anticipated my inquiry, which is, so we think that the booster uptake matches the earlier vaccination uptake levels, which would mean that these cities like Palo Alto and Mountain View and Los Altos Hills and Stanford would be among the highest in terms of booster levels. But notwithstanding that fact, they are undeniably the highest in terms of the prevalence of COVID per your sewer shed measurements. Yeah.
That's right. But I also want to underscore that the booster levels are not high anywhere. They're not high anywhere. So even among the older age groups who have the highest boosters, they're not even over 50%. So overall, it's 20%, but no group has a very high booster rate.
Well, let me ask, I'd like to ask if we could get for the entire board, for the entire county, disaggregated data on booster levels by city.
Booster levels by city. I think we could pull that.
And is that something we could get by close of business and an off agenda report on Friday?
We'll do our best. So booster, it's the Omicron booster. So the other point I want to make, I saw.
Hang on a second, Dr. Cody, forgive the interruption, but I want to be clear about what I'm asking for here, so your time is well spent. Colleagues, I think it is beyond baffling that one of the areas that has the highest uptake rate, and these are areas that are, well served by, in theory, by private providers, nonprofit providers, academic providers, and with a big shout out and thanks. There is a clinic in Mountain View. Thank you to the city of Mountain View for their cooperation. Thank you to our public health department. Thank you to our Valley Medical folks. But I mean, there's easy access in Mountain View for folks in Palo Alto, Mountain View, Los Altos Hills. And there's been some advertising of that. And so with all of that going on, it is baffling to me that we have, this dramatic increase. And I'm of the view that we better figure it out sooner rather than later, because just saying, gee, that's interesting isn't going to get us a better result. And I was inclined, and again, Dr. Cody, you were very insightful. You can see where I was going. I was inclined to think, well, is there some reason to believe that the booster rates there are lower for some reason that I can't fathom? But the inclination is on your part is to say, no, that's not likely. So I really do think it would be helpful if we could get the numbers and see, understanding that 25% is too darn low. But if we get the number anywhere, but if we get the numbers for every city and town in the county, that would help establish either that that's not the problem or that perhaps it's the problem, even though we don't know it. And if there's a way to get that
Supervisor.
information for East Palo Alto, notwithstanding the fact that they're in another county, and understanding that that might take a little while longer, I would encourage us to get that information because, if that is in some way, producing a different result in the data, but it's an awfully small community to have that big an impact when you look at the spike.
Supervisor, here's what's on the website, which is by census tract, the booster percentages. I'm not sure when this was last updated, but you can see that the highest percentages of boosters are in the northern part of the county and some in the middle of San Jose, the dark green. But then there are other areas which are very low.
Mhm.
Yeah,
so
and again, I'm just trying to understand why, looking, for example, at that area that from my vantage point here looks to be East San Jose, the white grids there, or census tracts rather, indicate a low take-up rate. Yes.
Mhm.
Yes.
And yet that the number is dramatically lower for San Jose and dramatically higher for the North County, which again is to me inexplicable and so far hasn't been clarified by virtue of this discussion. And I appreciate the candor about the fact that if we just don't know at this point, we just don't know. But I do think it would be helpful to get city by city numbers and sort of also keep focused on, well, then what's going on in an area where the number is shooting up, because we got to figure it out.
Yeah, so I just wanted to really underline the point that the boosters, one is they're low everywhere, but two, the booster rate at this point is not going to be as helpful as it would be with other mitigation layers. So there may be, for example, maybe there's less masking in North County, or maybe there's more indoor gathering in North County, or maybe there's some behavior that's different. So we would have to look at more than just boosters.
Yeah.
That being said, yeah, we'll definitely pull the data by city on the bivalent booster. So
Thank
and
you.
ship that back.
Thank you. And Dr. Cody and Dr. Smith, I want to be very clear. While I'm obviously troubled by this number for North County, I think the answer to this question has implications for the entire county. This is because if we don't figure this out, we can't be surprised that the phenomenon occurs somewhere else eventually as well. All right. Thanks very much. I'll look for that information. Appreciate it.
Thank you. Supervisor Lee.
Thank you. First of all, Dr. Cody, I just want to say I was very surprised and glad to see that the innovative wastewater monitoring program for COVID is being covered by the PBS NewsHour, which is a national coverage a couple of weeks ago. And with you being a local celebrity, explaining this importance of this work of tracking COVID in our community nationwide. So I just want to say thank you for doing that for our nation, and hopefully that will help other communities as well. So thank you. Given the 4 sewer sheds, that shows the increasing concentration of COVID now, and the fact that the numbers, as I said earlier, I think, wow, that how high numbers in Palo Alto. I think that's what prompted a lot of questions from our colleague Supervisor Simitian. First of all, do you even see a need of some type of a potential new public health order coming up?
Well, what I can say is that 3 years in, with all of the tools available, I would hope that something like that would not be needed.
Mhm.
You know, what I would really like to do is make this information known. We did press earlier today to share this data with the public as well, and hoping that information will move people towards some behavior change, move people towards the understanding that they do need to protect themselves in many ways at this point.
Right, because what it seems to me based on the wastewater data, that right now COVID basically, what you could say in terms of community infection is probably the very high, if not the highest ever since we started based on these numbers. Isn't that the truth?
Right. I think the way I think about the wastewater data is it's a very good way to understand what is your risk of exposure, how
Mhm.
much viruses are circulating around,
Right.
and then so how, you know, how many layers of protection should you add on given the risk of exposure. And so right now I'd say the risk of exposure is high,
Mhm.
and as many layers as possible are a good thing.
And if you recall, we used to have the black, the red, the orange, and all those different tier. And based on those old tier method, would you say we are in the red or the black at this point?
Gosh, I can hardly remember those tiers, but you
Right.
know, what's important is that those tiers were based on case rates. And I think we can all agree that the case rates don't really have a lot of meaning now,
Mhm.
because people aren't testing. So
Right.
it's hard to say.
Right. In terms of the different strands, I know we're hearing some of these BQ1 or whatever the new variants are. Any ones that you would like to share with us that we should be aware of? That's the new ones that's becoming more dominant.
Well, what's interesting is that at the moment, we have sort of a pretty even split between 3 different variants, that there's not a dominant variant. There's not one that seems to be outcompeting the other. You know, that can always change, but
Mhm.
the variant soup has gotten complicated enough that I can't just kind of roll them. They don't roll off the tongue the way they used to, shall we say.
Mhm. Okay. Well, speaking of incentivizing, I think people need to be incentivized a lot of times to do things. If you recall, we used to give out, was it boba tea to incentivize the teenagers to get their shots. I guess my question here is, do we have any type of incentive that we're working on, try to get more people to go out and get their, both not just the bivalent shot, but also the flu shot as well?
Well, I'm not sure I'm the best person to answer that question. I know at the county's mass vac sites, maybe Dr. Smith can speak to that.
Dr. Smith.
Even though the county still has a substantial place in the market, that being, by that I mean, you know, we're giving lots, a high percentage of the vaccinations. The retail pharmacies have sort of taken over, and so we don't have a specific incentive right now at the mass vac sites, which really just boils down to 2 sites, well, 3 sites. But we certainly can look into it.
I don't know, something as little as a $5 coffee gift cards or something, so people come and get the free coffee. I mean, just for boba tea, whatever it might be, right? I think we just need to be a little bit more creative because we are trying to get more people vaccinated, and given the numbers we see, certainly the need of getting vaccinated. I think it's felt like, you know, we're so sick and tired of it. We've got so much of it. We've already vaccinated so many times. Why do we have to do it again, right? That's the chorus that we keep hearing. And I think it's so important. And then also they think about masking, right? Oh, I'm so sick of tired of masking, but you know, at the end of the day, that's one thing that would block any variant. Supposedly give the best protection regardless of what variant's coming through. So those are things that we still have to remember. And I guess last thing I was going to ask regarding wastewater issue is there any type of takeaway you might have regarding the Gilroy and Palo Alto number, why they are so consistently higher than Sunnyvale, for example?
Well, I think my big takeaway is not to look at the differences between the sewer shed, but rather to look at the overall picture in the county.
The trend.
And
Mhm.
the trend and the overall picture and the overall trend is that concentrations are, one, increasing very steeply, and
Mhm.
two, they're already very high. So I
Exactly.
think the message for anyone living, working, or playing in Santa Clara County is that your risk of exposure to COVID is pretty darn high,
Mhm.
and there are many other viruses circulating. But there are things you can do that will protect you from all of them. And those are the common sense things that we all know. So to please take those common sense things to heart and practice them. And nobody has to be perfect, but more is better.
Right, absolutely. Shifting gear to the RSV questions. In terms of pediatrics, hospitalization of ICU beds and pediatric beds, do we see that if RSV is now straining our healthcare system for our kids?
The pediatric system has been under significant stress from RSV. We are seeing a softening in the RSV, the positivity rates, and the wastewater, which we hope will translate to easing the stress on the pediatric beds in the hospitals. But for example, we in our pediatric hospital, the system has had to do a lot of work to ensure that there's a bed for kids that need them. There have been kids that have spent more time in the emergency department than is optimal before being able to go into a bed, things like that. But hopefully when that eases, and that will ease the stress on the pediatric system. But the adult system is also under enormous stress, as we talked about from the viral soup.
Right. Now, in terms of the pediatrics, do you see that the number of occupant, in other words, is increasing to a point where we are getting close to being full, or how are we doing on that?
So I can't share any specific numbers, but I know the pediatric beds have been, as full as they've been in recent times. I'm sorry, I don't have specific numbers or data to share with you.
Sure, and again, not having it now, but maybe in the future meetings, and if it's appropriate, that let's say we are starting to run out of pediatric beds or ICU beds for kids, for peds, I think it's something that we certainly would like to know, so that we're planning for the worst, right? In case that were the case. Are there any type of specific demographic data for RSV patients right now, or is this basically throughout the county?
The RSV, I don't know that there's that many differences geographically, but as you know, RSV really poses the greatest risk to young children, particularly children 2 and under, and also to people who are older. So, and of course, a challenge with, for the most part, kids are resilient and are healthy and rarely need a hospital bed. And not every hospital has beds for pediatrics. So in our county, for example, it's Valley Medical Center, Packard, and Kaiser that have inpatient care for kids.
Right. In terms of RSV per se, in terms of the avoidance is no different from flu and COVID, right? Basically, like you said, but washing your hands, some social distancing, wearing masks when pack up, especially indoor. Those are basically the same things we can do, correct?
Yeah, RSV, the really important thing with RSV is stay home when you're sick. If your kids are sick, keep them home. And for RSV, as Supervisor Chavez was mentioning, RSV does spread by contaminated surfaces. So cleaning and hand washing are especially important for RSV. Masks are helpful too.
Right. So more stringent cleaning of the surfaces, doorknobs, things like that. Okay.
Yeah, and stay home when you're sick.
Stay home when you're sick. Okay, great. Well, with the data we're looking at, it looks like we are headed to this dreaded, we call triple-demic of flu, RSV, and COVID. And I'm not sure if this is a question for you or for Renee or Paul. How are our healthcare system preparing for what's coming, or if it's already here?
I'm not sure, Paul, are you there?
Doesn't look like.
I can give you an overview. Right now, we're preparing, we've got the capacity to bring on extra staff. We've got beds that we're activating. We've got permission to put some pediatric patients in our neonatal intensive care area, obviously separated from neonates significantly. And we've got disaster plans in the case that we need to expand outside and have tents up, which is unlikely. But VMC and O'Connor and St. Louis are very full right now, and the emergency rooms are very full, and they're seeing lots of respiratory illness. So a lot of our preparation for kids has to do with transferring to centers like Lucille Packard or Oakland Children's, because as Dr. Cody pointed out, we only have a few inpatient pediatric beds in our capacity at BMC, and there are beds, inpatient beds at Lucille Packard and Kaiser, but that's it. The county is, as many areas, doesn't have a lot of inpatient pediatric beds.
Right. And I guess one other question I have is regarding, having people stay home when they're sick. So if we get to a point that we're that full, would it be a situation where we would recommend people just basically try to recover at home, and then what type of helps we can provide to people if we cannot admit them?
Well, this is a challenge. Of course, if a child is sick and needs acute care, you really want the child to come in and be evaluated and admitted if needed. On the other hand, kids that don't need acute care, you don't want them in the emergency department, because you need to make space for the really sick kids. So that's where a lot of telephone work and advice nurse work comes in, as well as education from providers of the community about when to bring your child in and when to stay home and do symptomatic care.
Right. My last question is regarding logistics. It's my favorite topic. Do we have a need of storing more oxygens in preparation for this, in case things get worse?
Well, I think that would be something that each acute care facility would be accounting for in their own surge planning.
I think Paul can give you the answer for our 3 hospitals.
Thank you, Dr. Smith, Supervisor Lee. The system does look at our supply chain issues relative to any surge that comes about, including, in this particular situation, oxygen needed for our facilities for our patients. So we are monitoring that very closely.
Right, because I don't know, as you know, with that this is a triple pandemic. Obviously, if we need more oxygen too, I'm sure other areas of the systems would have that. So if you see that there's shortages of the supply because it's been used by other areas, I think all that could be indications that that could be the canary in coal mine, since our weather tends to be more temperate than many of the other states in the East Coast, for example, in the North. So I just want to make sure that we are monitoring it, and if need be, just to make sure that we are ahead of a game to, maybe just make sure logistics, make issue inventory of it, just in case we might need it down the road. Yeah, thank you. That's all I have. Thank you.
So you've got, all right. I'm just going to add in one last comment. Dr. Cody, and everything I've heard, I think whatever you can do, press conferences that you're doing to raise awareness, I think a lot of people are complacent. I think some people are very aware if they have family members with respiratory or flu symptoms at this time, what's going on. But I think if we raise awareness of what's going on in the watersheds, what's going on with the counts, et cetera, that's going to motivate some people to say, you know, holy mackerel, you know, this isn't over. We should get in there and get our booster shots. We should get in there and get our flu shots. And I think that'll be the least expensive way to increase our percentages up and over and up into the 75% range where I'd rather see them. Thank you for that. Dave, we have one speaker.
We do. Looks like we have a couple. Would you like to set the timer at 2 minutes?
Yes, please.
All right, one moment, please. Next speaker is Elizabeth Stewart. I'm unmuting you. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Hi, Supervisor Chavez, Supervisor Ellenberg. Thank you all for allowing me just a moment to share. My question goes back to the COVID shots and the booster shots. One is that what we're hearing mostly, the information about those shots is really coming from our county. However, there are lots of other sources that have indicated that there are concerns about the COVID shots. And so I guess my question is, why are we not taking into account some other medical information that's being projected regarding the harms of some of these shots that have been disclosed here on other news platforms?
Yeah, this isn't Q&A, so you have 2 minutes to make your comment.
Well, she has disconnected.
Okay, next speaker, please.
Next speaker is Irvish. You have 2 minutes. Please go ahead.
Thank you very much, Board of Supervisors, as well as the county staff. It is important that we follow the guidelines of WHO and CDC and set the paid-in rights of a vaccination such that to define what is the criteria for the prevention. It is equally important that when any particular set of vaccination that is being provided, it is equally important to provide the vaccination certificate to them, that they be validated in a way that they have the booster shot and the requirement be made. And as well as setting up the standards that how many booster shots or vaccinations are actually required for a particular candidate. So such that the research and eligibility criteria be made and also the right cure and the prevention be provided. There's no point of continuing with the booster shot unless there is a set guideline that has been provided at the level from the advocacy or a federal advocacy, either from state or the Department of White House. It is equally important that no matter what, that how many booster shots we take, but if we don't put the right preventions for that and set the standards for the eligibility or a threshold level, that how the booster shots are working out and making sure about that, whether that prevention and cure satiates the requirement for the cure or not, then and that it solves the problem of the pandemic leading the pandemic towards the endemic. Thank you very much. Muchas gracias a la Board of Supervisors y al personal del condado. Es importante de que sigamos las puntas de delamos. CDC, Y, establezcamos los derechos de patente de vaccinación de tal manera que sea criterio para la prevención. Thank you very much for consideration of comments in English and Spanish.
Next speaker is Sharon Luna. You have 2 minutes. Please go ahead.
Good afternoon, President Wasserman and supervisors. This report that Dr. Cody gave was very interesting, and being that I am on septic where my sewage goes into a holding tank, I'm curious as far as what studies have been done for those that are on septic systems in the South County. It was interesting hearing that Gilroy is on the uptake, and that is where our sewage goes when it's drained. However, it could take 1 to 2 years before we have our tank drained. My son did have COVID, and so I'm concerned as far as what is possibly being done to monitor the sewage that for residents that are on septic systems. I just asked my husband where our person takes our sewage, and he informed me that he takes it to Hollister. So again, it is, I don't know how many residents in San Martin or other areas are taking their sewage to other areas, which could, put a lower count as far as what's happening in the Santa Clara County or in Gilroy. Thank you very much.
Thank you.
And it looks like Elizabeth Stewart is back on. She spoke previously for 1 minute. Would you like us to reset the timer and give her 1 more minute, Mr. President?
Yes.
Okay, 1 moment, please, while we reset the timer. Elizabeth, looks like she's put her hand down.
Okay.
Elizabeth, if you want to speak again, go and put your hand back up. There we go. Okay, we're going to unmute you. You have 1 minute. Please go ahead, Elizabeth.
I'm sorry. I thought I took my hand down. No, my comment was just the same that I expressed earlier, just concerned that the platforms are not, there's not a diverse platform of information regarding the COVID shots. Thank you all.
Thank you. That concludes our request to speak.
Thank you, and thank you, David. And we will now move on to item number 15. Under advisement from the August 30, 2022 meeting, receive monthly report from administration relating to mental health and substance use as a public health crisis. And I'll turn to our COO, Greta. That's what my notes say, but I don't.
Good
There
morning,
you are.
President Wasserman. Can you hear me?
Yes, I can.
Okay, great. I guess good afternoon at this point
Yes.
to you and to the rest of the board. We are here for our monthly report on the behavioral health, public health crisis as part of our ongoing series of reports. And I am hopeful that this report will demonstrate for the board that we have much progress yet to be made, but we have been making significant progress on a lot of the service and programmatic and staffing expansion that have been our North Star as we move forward with urgency on lots of interrelated efforts to improve our system of care. So I'll go to the next slide. This is just a brief overview and really kind of a guidepost for what will be the areas of focus in this presentation and in this slide deck at this presentation, and also a preview of a few of the issues that we expect to highlight in the next presentation in January. We'll go to the next slide. And with that, I will turn it over to Sherry Trout.
Great, thanks so much, Greta. Good afternoon, President Wasserman, members of the Board of Supervisors, Sherry Trout, Director with our Behavioral Health Services Department. Good afternoon. I wanted to provide just a couple of highlights related to some of the efforts that have been taking place in our service delivery system. I won't read off all of these, but just highlight a couple of programmatic efforts in both our children, youth, and families and adult and older adult services. So on October 6th of this year, our REACH housing support program funding was extended to youth experiencing first episode psychosis. And also a redesign of our children, youth, and family ethnic program to improve access to care, coordination of services, and improve outcomes have been completed and will be implemented on January 1st of next year. Related to our adult and older adult services, as of October 31st, 2022, our Esperanza Self-Help Center walk-in navigator site in South County is fully operational, serving the community 5 days a week. And then our Trusted Response Urgent Support Team, or TRUST, began operations on November 11th of this year and expected to be fully operational by February of 2023. Next slide. This next part of our report out will be related to progress and strategies for behavioral health treatment facilities, including county mental health rehabilitation centers. Next slide, please. This particular slide reflects information related to our progress adding treatment beds at various levels of care over the course of the fiscal year, and reflects that we anticipate increasing our bed inventory by 205 beds within the current fiscal year. Some of the information we wanted to highlight related to each of the levels of care. At the far right, you'll see the anticipated bed increase within the fiscal year by percentage, as well as in the column to the left of that, the projected bed total as of the end of this current fiscal year. Next slide, please. This next section updates the board on treatment facilities. One of the updates that we wanted to provide related to the contract with San Jose Behavioral Health is that we are still working on adding the 8 dedicated beds for sole use by the county, and that's those conversations are still in process. And I will now turn it over to Jeff Draper, who will provide an update on the 77-bed acute psych facility.
Yeah, hi, it's Jeff Draper from the Facilities and Fleet Department. Our picture is a little dated after demo, it says here down below. We actually have most of the street that's right in front of that picture already demoed, and it's also filled in with utilities at this point. We've been making great progress on the excavation to the bottom of the basement for the new facility. We're still on track to pretty much get that particular part of the project done by the 1st of February, at which time we're planning to transition the project over to WebCore. The contract with WebCore is just right at the finest, the final moments to get signed. We're pretty much there, and we're hoping to finish it out this week. So that's where we're at with that particular project. Back to you, Sherry.
Awesome.
Great, thanks, Jeff. We'll advance to the next slide, please. This particular update is related to subacute care updates. We noted last month that on October 31st, we contracted with Crestwood for 20 dedicated subacute beds, and a contract will be further amended to add the remaining 25 beds beginning in fiscal year 2023. The other new update that we wanted to share is that we're currently working on negotiating a contract with another provider for up to 32 dedicated subacute beds related to residential treatment facilities. As we previously stated, on October 18th of this year, we contracted with ANA Healthcare, which added 11 dedicated residential treatment beds. And I'm going to go ahead and turn it back over to Jeff Draper to provide an update on 650 South Bascom.
Good news, I should say optimistic news today on 650 South Bascom. The property manager and construction contractor gave us a hint that they may be able to finish the project, at least from their perspective, a certificate of occupancy at least a month early on 650 South Bascom. And I believe Behavioral Health is still planning to open that sometime a couple of months later. I'll leave it back to Sherry at that point.
Great, thanks, Jeff. Finally, the last point we wanted to highlight was we've been discussing 101 Jose Figueres in previous reports. And we've been reporting that we have been exploring potential expansion of the beds at that existing county facility. However, our conversations with the California Department of Healthcare Services indicates that the facility cannot be renovated to add a third licensed or unlicensed unit under existing state rules. So we're continuing to explore other opportunities that we may have at that site. Next slide, please. And I will go ahead and turn it over to Deputy County Executive Key Lee, who will take us through the next section of the presentation.
Thank you.
Thank you, Sherry. The supported shelter effort is one that is led jointly by OSH and Behavioral Health, but also will be giving the presentation today. Supported shelter is a critical service and resource that we're trying to provide. And as we sort of indicated before, these are facilities or programs within facilities that are trying to provide temporary shelter or housing for behavioral health clients, with direct access for behavioral health clients who are homeless, whether they're recently homeless or long episodes of homelessness, including individuals coming from or being discharged from higher levels of care, like residential treatment facilities or subacute facilities. It's temporary. The key is that it's sort of temporary. The goal is to help people meet their basic needs, put them on a path to recovery and permanent housing. It's temporary in the sense that they typically don't pay rent, they don't have a lease, but they participate in the program and have their basic needs met. The form of these supported shelter programs is varied. Traditionally, we've had mainly congregate shelters, beds and open bays. We still have some of those, Now, more often than not, we have non-congregate shelters, facilities that serve dozens or maybe even over 100 individuals, and they may have private rooms or semi-private rooms. And sometimes the form of temporary shelter housing also includes leasing or renting a house and sort of letting people reside there temporarily, or sometimes acquiring a home. On this slide, there are sort of two of the first bullets represents that last piece, which is we have been working with several contractors to acquire or lease homes. And they'll be using sort of the rooms and the bedrooms in those homes to provide temporary shelter. Here, we state that we're working with mental health systems to work on 31 more beds by the end of the fiscal year, and then community solutions for 30 beds sometime in February 2023. The fourth bullet is an item that's also on your agenda today. Behavioral Health submitted a grant application to the state, and if awarded, they'll use that to help acquire a home, and that home will serve hopefully up to 8 individuals. On the third bullet, it describes another avenue that we're pursuing, which is to leverage the new monies that are coming from the state to establish these emergency or temporary shelter programs, primarily funded by the state's Home Key program. As you may be aware, there are sort of 3 Home Key awards for temporary shelter sites. Once those are fully implemented, there'll be about 400 beds. Our intention is to work with those project partners in those cities to identify to what extent some of those beds that will be developed could be set aside specifically for to meet the temporary shelter needs of behavioral health clients. Then as new awards are announced, we'll try to do the same, and we'll bring back updates to the board periodically. Next slide, please. So the Behavioral Health Department, I believe, has done a really good job of reaching out to existing providers, issuing an RFQ. The results of that have been a contract with ANA, negotiations with San Jose Behavioral Health, etc. And what we hope to do, and what we've been working on, is to create a sort of more formalized but flexible process by which we will continuously or on a recurring basis have the ability to receive, assess, contract for, or recommend funding for contracting for existing beds, or working with developer operators to develop new facilities at all levels of care. We think that taking a little time to sort of issue these types of solicitations will result in sort of better outreach, make it easier for our community partners to apply, so they be clear about sort of what our expectations are and sort of what documentation we're looking for. It's also a continuous or recurring process. So, if an agency doesn't have the ability to provide a service now, in 2 months they may have, but they'll still be able to sort of participate. And then it also gives us an opportunity to sort of collect up all of the existing opportunities and sort of evaluate or assess them, and then make the best recommendations that we can at that time. So the next few slides sort of describe the specific actions that we're implementing right now. The first was discussed somewhat at the last board meeting. Behavioral Health Department is working on a contract with a consultant to do a needs assessment of the number and types of beds, or the number of beds at each level of care that our community needs. We have a sort of a working target for the different levels of care, but I think this work will allow us to have a sort of more refined and more precise estimate of need. The second bullet is an RFSQ for the 4 levels of care. You may recall that the Behavioral Health Department issued an RFSQ for social detox. They're receiving some proposals now, and we're bringing some forward as soon as they've had a chance to evaluate those. We intend to do the same, but for all levels of care. And again, this will allow all project partners, community partners, sort of both in the county and outside the county, to submit proposals for us on a continuous basis. The Behavioral Health Department is also working with the Behavioral Health Directors Association and some neighboring counties to identify perhaps some opportunities to partner on establishing a subacute facility for persons who are determined to be incompetent to stand trial or Murphy conservatees. We'll have more information for you in January because I think it's important to have that conversation in context of the changes throughout the state around that specific population. And then lastly, on this slide, the board had some discussion last board meeting about cost analyses, looking at different options with county-owned properties, and we're working with our consultants to get a contract for that. This will allow us to do really two things. One, help us evaluate proposals if they come in, and two, to sort of understand what is feasible on some county-controlled properties, which will be very important for the next item. Next slide, please. As that slide is moving forward, borrowing from the successes that we've had with Measure A, we plan to issue a sort of a two-pronged RFSQ. So this solicitation will have sort of two results. The first is to identify a pool of developer/operators. These are organizations like Telecare or Crestwood, who have experience both in operating treatment facilities and developing facilities. And we'll establish a pool of these qualified developers. And then once we've completed our feasibility studies and sort of had the appropriate conversations and direction from the board, we can turn to those developer operators and request proposals both for development, financing, and operation of facilities. And the RFSQ will also result in an opportunity for developer operators to submit proposals directly for which we can evaluate. Here, we're asking them to consider properties that they already own or plan to acquire or renovate or lease to develop new facilities. And we're working to sort of issue these relatively quickly, then get information back so that we can properly plan for or take some actions at mid-year or at the end of the fiscal year. Next slide, please. And with that, I'll turn over to Consuelo Hernandez.
Thank you, Key. Good afternoon, Board President Wasserman and members of the board. Consuelo Hernandez, Director with the Office of Supportive Housing, and I'll be providing an update on the permanent housing strategies. Next slide, please. If you might recall, earlier this year, the administration presented a number of housing programs and initiatives to focus both in its short and long-term goals to address a continuum of housing needs. On this slide is an update that talks about our housing stabilization program, which we are now calling the Behavioral Health Emergency Rental Assistance Program, and our transitional housing or our REACH housing support program. You will note the updates here. Our team and Sherry's team have been working very hard together to develop a workflow that is in alignment with our current housing system so that we are not recreating the wheel and also leveraging some existing partnerships. With that, our hope is that we will have a contract executed by the end of this month and have a program that would start no later than February 1st. I'm happy to report that we have a template of a workflow that would allow us to have a dedicated person on the behavioral health side, a dedicated person on the OSH side, making sure that people are not falling through the cracks. In terms of the REACH Housing Support Program, the program started operating on October 6th. And just like any new program, there's always a bit of a delay in the beginning in terms of getting the maximum capacity in serving our clients up to speed, if you will. but we continue to work with our colleagues in behavioral health to provide long-term and rental financial assistance to youth and young adults that are experiencing that early onset of serious mental illness. We're able to leverage the existing work that behavioral staff has been doing and identifying any additional improvements to the program as we move forward. Next slide, please. Within the permanent supportive housing strategy, there are essentially 3 key objectives. The first is to expand our tenant-based rental assistance. I know a lot of folks don't always understand the different types of housing interventions for permanent programs, but there are different ways that people are provided with assistance. One is either through a voucher, if you will, known as a tenant-based rental assistance, where folks use that subsidy and rent in the open market, or 2, in the apartments that we are building through Measure A by leveraging also the No Place Like Home funding. So we currently in the Office of Supportive Housing and the Behavioral Health Department separately have and administer a tenant-based rental assistance program. Our recommendation is that we work together, expand that program, and launch it in March 2023. We have started working with potential providers that can help us launch this program. Apartments, we originally reported to you that we would increase the number of No Place Like Home units of 219. That new number is now 379 units across 12 developments. 4 of those developments are currently under construction. And the images on the right show those that we are expecting to open early next year. And then the last strategy is expanding care for people who can't necessarily live independently in an apartment or benefit from something that is smaller in nature and known as a residential care facility. A few updates for you here. On December 2nd, the Office of Supportive Housing, using our existing requests for offers and our developer qualified pool, issued an RFO for 3 county-owned properties to construct new residential care facilities. We anticipate those applications or submissions to be due early next year, and then we would return to the board with the awards for development partners. And then we're also working together on an application for community care expansion program, which would allow us to leverage those dollars for the construction of the preservation of existing RCFs, and the county will be issuing this solicitation in January 2023. Thank you.
Thank you. All right, we have a couple of speakers. David, if you have them speak, please.
All right, one moment, please, while we get the timer up.
And my apologies to President Wasserman. I believe Edwin Poon was going to carry on the presentation after me.
Oh, I'm sorry, Consuelo.
Apologies for that.
Hey, Edwin, go right ahead.
Thank you. Good afternoon, Board of Supervisors. I think we're not quite done yet, so if we can put the presentation back on, the slide back on, that would be great. I think Behavioral Health still have a few slides to go over. So Supervisor Wasserman and Board of Supervisors, I'm here to present the next few slides, which is related to withdrawal management updates. So next slide, please. So the last time I presented to the board about withdrawal management, there was a request to provide additional information about referrals process for withdrawal management. So here I wanted to outline to the board the 4 different ways to make a substance use treatment services referral here. The 4 different pathways include the first one, the appointment base, which is basically through our gateway call center, where the beneficiaries will be receiving information about providers and then can go ahead and schedule services directly with the provider. That's covered primarily most of our outpatient services. The second way to make a referral is through what we call post-authorization, which is basically directly screen and refer beneficiaries to treatment providers. This is an important pathway because not all services we wanted the beneficiaries to call the gateway call center to repeat the information. And so there are some services that referral could be made directly by agencies, including our court system, VHHP, hospital system. The third mechanism is through care coordination. So this is very beneficial for those individuals who have special needs, particularly those who have may have high use of treatment services, need special care coordination. So we do have staff, utilization management staff, to specifically to assist those clients to coordinate care. And then the last mechanism is what we call same day, because we do have some services that we offer same day access to outpatient intakes, and residential placement also fall into the category because what we wanted to do is to avoid or reduce early termination. Under social detox is where you will see most of the post-authorization mechanisms takes place. And I want to reiterate that for medical detox, it is generally accessed through emergency department. And also the reason why medical detox is not covered under our four different pathway here illustrated here is because it's primarily not a benefit that are covered by the managed care plan partners. So that's Anthem and Family Health Plan. Next slide, please. So I wanted to update the board on the social detox, bed capacity, and referral tracking. The first capacity tracking system is the system that we developed actually back in June. We have shared with the board in the past about our point-in-time tracking that demonstrate or shows available beds versus the total capacity for residential care facility. And I wanted to mention here that it also includes social detox bed. And the dashboard is currently available to the public on our BHSD website. The second mechanism, which is the most latest development, is what we call social detox referral tracking. It was launched late last month. It is currently in a pilot phase, so we are gathering feedbacks from our provider before finalizing the tracking log. So we have designed a tracking log which include some additional information that our current capacity tracking systems is not capturing, and that's included the number of referrals that each of the facilities have received, the number of admissions that they have, the number of discharges, the number of referrals that they have rejected, if that's the case, if there's any, and also any clients that are on the wait list. We noted that in the past that the Board of Supervisors, you guys have asked us to potentially capture the information of wait lists. So our intention is that this social detox referral tracking will allow us to do so. The last slide, the next slide, I should say, for withdrawal management, is our social detox network update. So I wanted to share with all of you that Pathway has hired 6 new staff. There's still 1 pending and 1 opening. So that's the latest reports that we received from Pathways. I also wanted to mention that they have eliminated certain COVID-related practices that have limited their capacity. So the capacity has increased and opened up to both on the residential as well as social detox. In terms of the RFSQ, I'm happy to report that we have received 2 proposals since we released the RFSQ back in October 7th. So we're in the review phase right now. So the RFSQ continue to be open. So we continue to encourage any other providers to submit their proposal. And this is for our social detox beds. The third bullet covers the current process that we have and also strategy in terms of supporting withdrawal management and residential treatment for youth. So we have been working with our contracted facilities to ensure that we have the maximum flexibility when it comes to treating youth in combination of both withdrawal management and residential treatment. We are reviewing the 2 social detox proposal that I mentioned earlier and wanted to consider whether they also have capacity to meet our youth adults at the same time. And then the last bullet point just talks about we're continuing to reach out to any potential social detox provider in the Bay Area. I think that concludes my slides on the withdrawal management. And I think next is going to be Darren Tan and also John Mills to cover the workforce strategy.
Thanks, Edwin. Good afternoon, President Wasserman and members of the board. So our department, in partnership with our Employee Services Agency, Behavioral Health Contractors Association, and other community partners, has launched strategic efforts to address the behavioral health workforce shortage. As you can see in the slide, BHSD has continued to leverage our collaborative work to implement critical strategies toward the objective of addressing and fortifying the behavioral health workforce across the network. The strategies are as follows. First is enhance and leverage partnerships via working groups and collaboratives to ensure comprehensive planning and implementation efforts that include the voices of our community providers. The second is to strengthen our workforce pipeline through the creation of a pathway to permanent county employment for interns, as well as expanding student and peer internship programs, workforce tuition and loan repayment programs, and extra help staffing support where feasible. The third is the promotion of the behavioral health field by partnering with ESA through various strategies, such as enhanced marketing and outreach efforts, expanding our involvement in career fairs, and hosting virtual events. The fourth is to develop recruitment programs. Two successful programs that have been developed and currently in motion are our sign-on bonus program and the creation of specialized recruitments for prioritized clinical vacancies. We're very optimistic about these two programs, and we will be analyzing its outcomes and effectiveness. A follow-up will be provided in our next workforce report when more complete data is gathered. Additionally, the creation of unclassified positions that will offer a direct opportunity to fill a permanent position to graduating student interns in our program will be available in May. Lastly, we continue to assess the impact of our strategies and identify areas for improvement by conducting workforce analyses of our current recruitment campaigns, especially for our prioritized clinical positions and staff retention throughout the network. And for the next slide, I'm going to hand it over to our ESA Director, John Mills.
Thank you, Darren. Good afternoon, President Wasserman, members of the board. Can everyone hear me okay?
Yes, we can.
Great, thank you. As Darren mentioned, this slide highlights some of the key accomplishments that we've been able to achieve in our close partnership with the Behavioral Health Services Department over the course of this calendar year. Some of the accomplishments that you'll see highlighted on this slide include filling 42 prioritized clinical positions, which is double the number of clinical hires achieved in 2021. And we attribute that to our focus on specialized recruitment campaigns and community outreach and marketing efforts that we've undertaken in partnership with the department. We've also created an alternately staffed code with the rehabilitation counselor to allow for a pathway to permanent county employment for our interns. And as Darren mentioned, as a result of the sign-on bonus program, which was recently implemented, we've been able to fill 10 prioritized clinic positions. And lastly, our clinic operations will be strengthened with the upcoming implementation of the licensed clinical supervisor classification and also the crisis intervention specialist classification that we anticipate by the end of this calendar year. And with that, I think I'm turning it back over to Darren to conclude our workforce portion.
Thanks, Sean. So as far as next steps, building on the momentum of our work thus far, we will continue to collaborate with our partners to address the behavioral health workforce shortage. The following are some key next steps that we will take in the coming 6 months. Through our partnership with ESA, we will assess the outcomes of our community outreach and specialized recruitment campaigns, sign-on bonus program, and assess the success of our student intern program through the number of graduate transitions into permanent positions, as well as implementing the new classifications that John mentioned to support our clinic operations. And through our partnership with the Behavioral Health Contractors Association, we will analyze the vacancy, retention, and fill rates of clinical positions of our network, as well as continue the expanded implementation of the workforce tuition and loan repayment programs across our network. A detailed analysis of our findings, both internally and with our providers, will be provided to determine more measurable outcomes, benchmarks, and goals. And the next slide. And so lastly, our department has been working collaboratively to fill 110 new positions that were added from July of 2021 through November of this year. The following list provides a detail of the prioritized positions that were added and the current rate that these new vacancies have filled. Currently, 64 positions have been filled, highlighting some successes of recruitment specific to various programs and offering insight into programs where further work is needed to attract quality candidates. In addition to the staffing plan of prioritized programs, the county has allocated supplemental resources to support the clinical behavioral health workforce shortage. Our accomplishments and progress thus far are also the result of this cross-department collaboration across various county departments listed on the right of the slide, and increased utilization of extra help where feasible. And we will continue to leverage these resources to address the behavioral health workforce shortage until permanent positions continue to be filled. And I'm going to hand it over to Sherry.
Great. Thanks so much, Darren and John. Before we conclude this section, I just wanted to provide some additional information. The information we've shared thus far is really about the ways in which we've been recruiting and filling vacancies and trying to bring in new folks to fill existing positions, ensuring that we're addressing our vacancy list. But I think one of the critical areas of importance is not only that we're continuing to focus on recruiting, but also our efforts to engage staff and actually retain existing staff that we have in positions. So just to share briefly, some of the common themes that we have seen surface in our surveys of our staff, of our listening sessions, and our engagement in conversation with our teams have been themes around acknowledgement, so wanting to be acknowledged for the really good work that they've been providing. Secondly, communication, really wanting to have improved communication around all of the efforts that the department is involved in. Third, pathways for professional development. Fourth, a focus on workplace morale. And fifth, work-life balance. And so we have taken all of that feedback to the department. We've created an employee engagement advisory committee, as well as a race equity and leadership learning cohort. At the end of September, we had a large event, all staff event for our entire department, both acknowledging years of service as well as a DSW recognition for the many disaster service workers that came out of behavioral health to support during COVID and the pandemic. We've issued a monthly BHSD leadership circle email to inform staff of what's happening in the department, and at the same time acknowledging, really highlighting the great work that's happening, as well as really enhancing training and professional development opportunities through email announcements across the department, as well as engaging more frequently in weekly team huddles, offering virtual meeting options, coffee breaks, and listening sessions. So those are just a few of the strategies that we have been implementing in the department, of course, focusing and continuing to focus on recruitment, but at the same time, really highlighting the value and importance of retaining and engaging our existing staff and teams. So with that, I'm going to go ahead and transition to the final part of our presentation, which is really focused on the Mental Health Services Act and 2011 Mental Health Realignment Fund balances. Next slide, please. This particular slide focuses in on our MHSA fund balance. We've been bringing on a regular basis to the board our MHSA plan, whether it be our mid-year adjustment, annual update, and or 3-year plan. But we wanted to highlight that at the end of fiscal year 2022, our fund balance was about $102 million. And recently, using the Legislative Analyst's Office MHSA revenue projections, the county's projected expenditures for MHSA funded programs and services would essentially reduce the MHSA fund balance to $59.7 million by the end of this fiscal year, and reduce the MHSA fund balance to $14.5 million by the end of next fiscal year. And then by the end of fiscal year 2025, the balance would be fully depleted and require an additional $27.4 million in non-MHSA funding to sustain services. And the non-MHSA funding needed to sustain services in the following fiscal year, 2026, would be approximately $50.4 million. So over the years, we've been quite focused on developing a very robust program and service offering through MHSA, but We've always noted that this particular fund balance is volatile. It's dependent on the number of millionaires in California, and that is what funds MHSA. And so when those parts of the budget and across the state are altered, it certainly has a significant impact on our local allocation. And so we're wanting to just bring this information forward so the board is aware of some of the trends related to the fund balance. Next slide, please. We've also shared updates previously on our 2011 mental health realignment fund balance. At the end of fiscal year 2022, our fund balance was $128.8 million. Our one-time fiscal year 2023 cost to improve our billing and claims processing has reduced that fund balance by $4.3 million. And when we look at an allocation to potentially offset projected MHSA deficits, that reduces it by $77.8 million, leaving a net balance of $46.7 million. And again, just we had shared this earlier in the year related to the source of funding and the utilization of 2011 realignment, but it really is around supporting expansion of mental health and substance use treatment services, as a primary funding source. And we will continue to work with our managed care system and staff and contractors to increase revenue levels that would allow services to be more easily sustained. Continue to support treatment services for individuals who would be Medi-Cal beneficiaries, but who are not enrolled or for whom services are not easily billable because of engagement or administrative challenges, as well as looking to fill funding gaps for treatment services if the general fund is constrained. Next slide, please. This slide highlights just some of the ongoing operational revenue strategies that we're promoting in looking at the various funding that we have for mental health services. So we're continuing to substantially work to increase Medi-Cal revenue for substance use treatment services, increase Medi-Cal revenue for mental health services, including expanding use of certified peer support for billable services, leveraging CalAIM and or other services under enhanced care management and community supports. We're also following from a policy and advocacy standpoint, operational and policy changes related to the IMD exclusion for Medi-Cal, as well as on November 1st, the board directed the administration to identify state and or federal policies, and we will be bringing that information back in our report on January 10th in the next report in the next month. And with that, let me see, I think we have one more slide. Great. Sorry, just to continue on, these are some of the other one-time opportunities that we have as additional revenue strategies. We brought some of these forward before: BHCIP and CCE, opioid settlement funds, capacity building through CalAIM, some of what we discussed today, leveraging existing home key sites or potential projects, and of course, the behavioral health bridge housing, which will be distributed statewide. And with that, that concludes our presentation today. And
All
we're
right,
open for
Dave.
questions.
Oops, I'm sorry. Thank you very much.
No problem.
Dave, we've got a couple members of the public wishing to speak. Would you allow them to do so?
Certainly. One moment, please.
Thank you.
Next speaker is Rocio Molin. I'm unmuting you. You have 2 minutes to speak. The timer will start when you begin speaking. Rocio, are you there? Rocio is not responding. We will move on. Next speaker is Elisa Koff Ginsborg. I'm unmuting you. You have 2 minutes to speak. Please go ahead. Elisa, your microphone is open, but we're not hearing you.
Can you hear me now?
There you go. Go ahead.
Okay, sorry about that. Good afternoon. I'm Elisa Koff Ginsborg with BHCA. BHCA members are committed to partnering with the county administration to move forward these critical components of addressing the public health crisis. The number and complexity of initiatives makes clear the urgency with which county administration are tackling this crisis. We share this urgency and are grateful to be partnering in many areas. Increased urgency for community providers also exists regarding CalAIM and specifically payment reform. A prominent state leader refers to this as the most fundamental change in the history of the behavioral health system. By July 1, 2023, the state will dramatically change how it pays for services, requiring the county and subsequently all providers to utilize entirely new ways to bill for services, including billing by CPT codes. The methodology of how to make these transitions is not clear. While this brings new opportunities, it also has the real potential to destabilize the entire system of care with devastating effects. Over the next few months, BHCA members hope to work collaboratively with the county as we tackle the enormous tasks of determining how transitioning to CPT codes can actually accurately capture the costs of continuing to provide comprehensive services in community settings, something much more difficult than office-based service costs. At the same time, we will be restructuring electronic health record systems and training direct service and administrative staff on how to utilize the new approach. Making this transition while simultaneously expanding services will require the best thinking of county and provider leaders. Thank you.
That concludes our speakers.
Thank you very much. And thank you for, this is a once a month report, and that was a very, very, very jam-packed. In fact, I think when Greta started, she said good morning to us. It was a very jam-packed, I'm just kidding. You all did an absolutely wonderful job, tremendous information, tremendous things happening. And it wasn't lost on me at all that the completion date was a month sooner than originally anticipated. So Sherry and Greta and company, great job, everybody. This is simply a receiver report. Supervisor Lee, do you have a question or comments?
Yes, I do. And actually, that was exactly where you lead me to start the question on about the 650 South Bascom's good news.
Yep.
That we're able to finish the construction, the TI, the tenant improvement, approximately 1 month earlier. So that's certainly music to our ears. And it mentioned something about a couple of months for us to get it implemented. Just trying to find out from our staff any way we could sped that process up from 2 months to something sooner, so we get open sooner.
This is Jeff. I'll defer to Sherry. I think there's a licensing process that's required, Supervisor Lee, and obviously that's really important. We can't really open it without licensing.
Of course.
Yes, Supervisor Lee, we are working with our contractor vendor to develop, the contract and agreement, and working with the entity that would license the facility. So we are working diligently to align that as closely with the completion of the facility itself.
Okay. Yeah. So whatever it takes, we can actually start earlier to move these things forward and start waiting serially. We could do it in parallel. And get this moving. Obviously, the goal is to get open, right? The fact that it's finished is not enough when it's not open to the public. So anything we could do to help, and let us know, Sherry, if we could be of help from the board's level as well to engage with the state if that's what it takes for OSHPD or whatnot to get it approved. Thank you.
Thank you.
Yeah, thank you. And I just want to say, thank you to also my colleague Supervisor Ellenberg for working together with our staff to push forward with this meaningful action to address the mental health and substance abuse as a public health crisis. And I want to certainly thank our county administration for moving very quickly to respond to the board's unanimous approval of these 10 charges from the memo submitted by Supervisor Ellenberg and myself during the board meeting on August 30th. Although we always have more work to do, as a county, we have certainly made significant progress in behavioral health since the end of August. Numerous tasks have been completed, and among the tasks that are still pending, substantial progress clearly has been made here. And one of those pending tasks is develop a plan for developing a county-owned IMD facility. And I certainly appreciate the administration taking a multi-pronged approach to address the need for the additional beds at the subacute level of care. Open-ended RSFQs, exploring potential partnerships with neighboring counties to develop facility, adjusting rates for subacute providers, and engaging consultants for cost analyses and feasibility studies of county-controlled properties combined to provide a fantastic start. I would like to also ensure that we follow through the county-owned IMD facility, given the bottleneck at the subacute level that we've discussed so many times in the past. To that end, I would like to better understand and ask for more detail on our plan to explore partnerships with neighboring counties and engaged consultants. I'm aware more information will be provided in January, but if there's any ideas on deliverables and timeline, that would be certainly most appreciated to help the board and the public to understand how we intend to move forward. And is anybody that might be able to give us some highlights to this question?
Sure, Supervisor Lee, I can maybe get started and then I'll transition it
Sure.
to both Sherry and Key and others who I think can speak to a couple components. And there was a lot to say in response to your question, but I hear the feedback that we've already said a lot. So I'll answer your question succinctly and say we are trying to leverage existing analysis that's been done statewide on some of these more nuanced capacity assessments, looking at providers that have already done a lot of the legwork and can hit the ground running to deliver us work product on that front much more quickly than someone who's experienced but coming more new to a lot of the data that they need to analyze. On the potential expansion of subacute facilities, you saw in one of the slides a reference to current exploration with a provider around 32 beds. I did just want to highlight the fact that that would be not just contracting for 32 existing beds, but supporting an expansion of the number of beds in our county. And more details will be forthcoming on that, but did want to make sure that was clearly understood as an expansion of capacity as opposed to just capturing more of the capacity that currently exists. And I can maybe turn it over to Key and Sherry if they'd like to add anything there.
Thank you, Greta. Thank you, Supervisor Lee. I think the only thing that I would add is that we sort of presented these items as sort of like distinct bulleted items, but really I think they're all sort of converging on a timeline that sort of allow us to hopefully take some action to support these activities at sort of mid-year and sort of, but certainly as part of the fiscal year 2024 budget. Maybe as one thing that we could do to provide a little bit more detail is, as we sort of finalize and begin to push prepare to push out the solicitations, share that sort of via off agenda, sort of with the full board, just for awareness. And then if there's sort of any questions that providers might have, they might bring to you, your staff or yourselves would also be familiar with sort of the expectations.
Good. Thank you.
I'll just add that we're engaging in the cross-county conversation that you referenced, Supervisor Lee, to engage other counties to see how they're addressing similar issues that we recognize are happening across the state. And so we are meeting with our regional partners to see what opportunities there are to share strategies and actually opportunities to really look at how they're addressing bed and housing issues, in the same way that we are in our county. So we'll continue to report back on progress made there as well.
Great, thank you. On the issue of the detox, so first of all, the social detox we mentioned in your slides, that pathway now has hired 6 new employees. So that's the 6 more individuals, and they're still hiring more. And that's from those 3.2 FTE that we provided earlier. Is that correct?
That's correct, Supervisor. Yes.
Right. Good. Good. Well, I mean, certainly that's music to our ears. So I guess my follow-up question would be, as we know, I think they had 15 beds supposedly. So I just want to find out now that with these additional employees, that those 15 beds are basically filled most of the time. I just want to make sure that's the case.
Yes, so we have just actually received the latest update from the Pathway CEO that all their beds are now available for any placement, that including both residential bed as well as the withdrawal management, the social detox bed. So they are reporting capacity to us on a daily basis. And they are, as the last report that I got is that there are no wait lists currently with Pathway, and they are not rejecting or turning away any referrals. So we are pleased for that information, but what we would like to do is continue to work with Pathway to make sure that we have direct communications and that we're receiving regular updates to make sure that the system is working smoothly.
So is it safe to say that they are basically no waiting, as in they could get same-day placements for the social detox beds?
That is the reports that we're receiving, and so we obviously wanted to make sure that if there are any buddy that has difficulty accessing the services, that we would be alerted. But yes, that's correct, Supervisor Lee, that the Pathway is reporting that they have all their contracted beds, both including the 56 beds of residential, as well that all their beds are currently available and can be utilized.
Good, thank you. Now, on the other spectrum, of course, we have also the medical detox
Yes.
program as well. I think administration have let us know that our 3 hospitals assist about 120 people per year for the medical detox services.
Yes.
And based on what I'm hearing from the community and also Pathway, that has raised concerns about not having a referral pathway for medical detox services. I just want to make sure we reconcile with the community and the providers' requests for medical detox versus the administration responses that you have.
Yes, thank you for that question. So as I mentioned on the slide that, and I think in the previous report that from the administration perspective, of course, again, that we want to make sure that anybody who needs medical detox can access medical detox, and the most direct route of accessing medical detox is through our emergency department, as well as potentially urgent care. The reason why we say that and continue to say that is because anybody who has a medical emergency and needs that medical attention, we do not want to put another layer of referral, waiting, and or finding a bed, so to speak, to delay any of those services. I think that our administration is always ready to speak to community providers, including our hospital system, as well as our social detox facilities, about care coordination. I think that is a really important piece. And then I also mentioned earlier that medical detox is a benefit that's covered by the managed care plan. So it is, we are working very closely and hard with our managed care plan partners that include Family Health Plan and Anthem to make sure that the care coordination takes place.
Okay, so as data says, 120 people per year for medical detox services for our size 2 million people. Not that we provide services to every single person, but those 120 seems to be fairly small. So I would like to see if I could ask administration to provide some data on the medical detox requests or referrals, the utilization of services, and provide any medical detox type of wait list if there's any. What I would like to do is if you could provide this information presented in the next withdrawal management update for the monthly referral report back, I appreciate it.
Okay, I'll take that referral back. But did I hear a question?
I was just going to hop in to say we will be happy to provide more information on that. And as you can see, Paul Lorenz has come on camera. He's also available to answer any questions about medical detox, since that's a service provided at our 3 enterprise hospitals.
Oh, great. Thank you. Oh, hi, Paul. Just a follow-up on the medical detox question. I was just saying the number of 120 per year seems to be very low on the need. I'm just going to get your take on these numbers. And is there a gap there between the social and medical detox that we're not getting people in the system?
Thank you, Supervisor. I think there's been some conflation around what's being offered relative to our patients in need regarding social versus medical detox.
Right.
I think working with the progress and the programming that currently Edwin Poon has described in the presentation, we'll get a better feel going forward around the particular need and utilization of those 2 services. And as always, we are more than happy to sit down with our community partners and community members to better understand their perspective around this issue, so that we do in fact provide a comprehensive service. And I think the most important thing that was mentioned is that, particularly around the acute medical needs or medical needs of our patients that are in this situation, we want to make sure they have the most direct access to the service. And right now, that's the way the system's designed. And again, if there's other ways in which we can further enhance the service, I think the first step is to sit down and discuss this with those that have an interest in this topic beyond what we're currently doing.
Okay. Supervisor? We lost you for a minute, Supervisor Lee?
It looks like he's reconnecting.
Okay. Otherwise, we'll move to Supervisor Chavez and then come back.
He's
Oh,
back
thank
on
you.
camera, it looks like. There he is.
Oh, there he is.
Yeah, I'm sorry. I think we have our technical issues as we have, but I'll go and listen afterwards for Ms. Lorenza's answer. So I apologize for getting off, but I think that's an issue that we certainly want to follow up on. Thank you so much. I'll pass it along. Thank you, President Wasserman.
Thank you, Supervisor Chavez.
Yeah, I'm going to start with this last discussion around medical detox. And I want to make sure that I understand how to tell somebody to access this service. So I'm on our county's website, and I don't, tell me what box, I'm on the county's behavioral health website, what box do I click on? So I mean, after I go to the substance abuse services and where I would know how to access medical detox. I have a withdrawal management, so I have a bunch of phone numbers. And I have medication assisted detox, but I can't find medical detox on our website.
Edwin, did you want to jump in on that, or did you want me to get started?
Sure, I can jump in here. Greta, please feel free to fill in the gaps as well too. So I think Supervisor Chavez, I think the primary reasons that probably that it's not necessarily included on the website, part of it is what I said earlier, that medical detox is a benefit that's primarily covered by the managed care plans. So technically, we're actually not, county behavioral health, but the behavioral health services department is not a payer of medical detox. So our role primarily has to do with care coordination, which means that anybody who is receiving medical detox through the managed care plans, including Anthem and Family Health Plan, we will assist that client when the client is ready to be transitioned from medical detox to other services, including social detox, residential treatment, or other outpatient services. That's when the county substance use treatment services really kicked in. So we do a lot of care coordination, say, when it comes to medical detox, but really the medical detox benefit is not part of our coverage.
Right. So Edwin, here's just to be crystal clear,
Sure.
everybody who's working on behavioral health.
Yeah.
The average person
doesn't
understand the difference between what one part of our organization does and another part. Our websites should be integrated so that it's really pretty idiot proof. I don't think anybody I've talked to, and by the way, even the fact that this conversation has evolved over the years of discussion on it, tells me that we don't have a very clear, integrated way for that service to be available to the public. And the reason I know that is I've listened to hours of this, and until today, but well, actually, our last meeting, someone said, "Oh, you just go to the emergency room," and I think that's, maybe somebody would know that. I think what anyway, so my point is that when this comes back to the board next month, there should be an integrated, clear, easy to explain way to help people navigate the system. Now, I recognize that there are many, many ways people connect to our system. I absolutely understand that. It's 988, it's 911, it's showing up with a broken leg, and then having this other service that you get provided to. I totally understand that. But the fact that I can't explain this to somebody in a dial 988 way, and if that is one of our options, we should be saying that over and over again. But the fact that the public shouldn't have to navigate between the two systems, period. It's too complex. And we're making it hard for people. We want to do the opposite. When somebody's ready, we want to make sure that they're able to go, into treatment right away. Am I off base? And Edwin, I'm not going to put you on the spot to answer that question. It's a little, I'm going to go to
I
Greta.
can respond to it. Yeah.
Yeah.
Yeah, no, I totally understand what you're saying. And I think Edwin was responding with sort of organizationally,
Absolutely.
how do we organize the service? And I think what you're asking for is what can I provide to community members who want to understand what the nature of the service is and how they can access it. And
Greta,
we can
even our service providers aren't clear on this.
Yes,
Not.
totally understand your request. We can absolutely come back with that. In a nutshell, though, now, because this is a medical service, it's for somebody who's experiencing really significant medical harms, that the place that the care that they need can be delivered is generally going to be in the hospital setting. And if they're experiencing those symptoms, they walk into the emergency room, they immediately get care. And we can do a better job of providing information to the community so they understand that.
Okay. Thank you. I really, I can't emphasize enough that that's not clearly understood even in our own system, even here. So yeah, that really has to be remedied. And I do understand, Greta, everything you just explained to me, because even that kind of clarity has not been what we've been told even at these meetings. And perhaps it's because when we are talking about behavioral health, we have one part of the system and not all of it together. But I think having Paul here is very helpful. I want to understand the implications of the insurance coverage that Edwin described on this particular topic.
So are you referencing Supervisor about the who's responsible for paying for the service?
Mm-hmm.
Yes. So the one of the limitations for us when we speak to medical detox again is because we are not the payer for the service. So we have limited. When I say we, I'm speaking of the Behavioral Health Services Department as the administrator of the drug Medi-Cal benefit. We have limited visibility because these are not benefits or services that we received claims or payment requests from hospitals when someone's is there for medical detox. So we do have limited visibility. So the payment, because this is considered a medical services, so these are covered under the managed care plan for Medi-Cal.
But the implications.
And they are a covered benefit for folks who are Medi-Cal enrollees. So the entity that manages their medical benefit as a Medi-Cal beneficiary is the entity who would ensure that they're able to access that care and get it paid for. They can walk into the emergency department and get the care, but then the payer is going to be their Medi-Cal benefit.
So just so I understand this, but the way, Edwin, were you raising the insurance because it reflects how the role of the of your department?
Yeah, yes, I think that there's a large part to it. I'm raising this role because as a department, as responsible for the drug Medi-Cal organized delivery system, we contract with the state as a payer. So we are in essence an insurance coverage for drug Medi-Cal. So that's why I raised the point of the payer. So when we talk about a Medi-Cal covered benefit, there are various different entities within the Medi-Cal system that will be responsible for this. So what Greta alluded to is that, yes, it is a Medi-Cal benefit, but it is administered or covered under the managed care plan. So because the service is covered under the managed care plan, the responsibility when it comes to how to access that service is the responsibility of that entity. If that makes sense.
And
It really
Edwin,
does.
sorry, Edwin, in our county, that would be Santa Clara Family Health Plan and Anthem, right, would pay for the service.
And we have Dr. Smith who's wanting to add in too. Go ahead, doctor.
I'll probably just confuse it, but this has to do with the carve-out concept. The fact that many years ago, the state carved out mental health care and substance abuse care from medical care. And so each county has a responsibility to essentially function as a HMO in their behavioral health and substance abuse system. So the state gives the county money and the county is responsible, just like an HMO would be, for the mental health care and the substance abuse care. But once you step over into the hospital or the clinics, that's paid for through Medi-Cal, straight Medi-Cal, which in our county is Family Health Plan, and it's a managed care system that pays for medical stuff. So when you say medical detox, even though we have been talking about it as detox, the state sees it as medical.
Right, and Dr.
At a different pot,
Yeah.
different pot.
And I guess, Dr. Smith, what's important for and thank you for that. And I think Edwin was, thank you for that. I think irrespective of the payor, I'm really just focused on how do we get information out to people that is useful. And I appreciate that what Edwin's raising is really the back of house issues. And I think where we want to be is in the less confusing, that really doesn't matter to the public. Mm-hmm. And all we have to be able to do is explain how it gets accessed, right? And that's not easy to access on our website that talks about drugs and mental health, right? So to me, that even if that meant that it was a link somewhere else, it should still be explained in a way that somebody who's trying to help somebody else or get help themselves can find that, and much easier, and that the system's educated. Because I will tell you, I've talked to many of our partners. Not one of them would have a consistent answer about how to access that service, and they're engaged with you and they don't know that. So that's really helpful. The other issue that this is kind of a broad question that I want to ask. I'm not sure the right person to ask this, but I am interested in understanding that if the county is responsible for people who have serious mental illness, if they are our charge, and I say that because that's what Dr. Smith told us at our last meeting. What I'm really curious to understand is, do we have a concept of how many people who are seriously mentally ill in our community that we are responsible for?
Sherry or Edwin, do you want to answer that question in terms of, I understand the distinction, I think, between the question you're asking, Supervisor Chavez, is how many people do we consider patients of our system of care?
I can kind of provide a broad kind of view of this, and I think this is actually a really good question, and I think that I have seen this questions also raised at the state level. So it really has to do with our population. I think that we have seen some state data that have talked about penetrance rate. So this is one idea where we can look at the general populations of Medi-Cal populations and how many people are served under the specialty mental health. So penetrance rate is one of the way that the system has looked at the populations in general, how many of them has specialty mental health. I'm going to pause here because I see Dr. Smith has his hands up, so maybe Dr. Smith has comments.
Doctor.
Try to give a layperson's description. In most populations in the United States, the incidence of severe mental illness, which is a term of art for mental health, meaning that you're very chronically affected and have trouble maintaining activity in the normal society, is about 9% for adults. If you add in kids, it gets up into the 15% range because that's where you get problems with developmental disability and the like. So if you just take 10% of 2 million, that's 200,000 people that theoretically in the population have that problem, but we obviously don't take care of all of them because of the penetrance problem that was being discussed by Edwin. Not everybody comes to care.
Is that what that word means? I was trying to look it up, but Edwin.
Yeah, it is. So you have the baseline of population, supervisor. So baseline population is what Dr. Smith had described. And then the term penetrance means that of those baseline populations who think you believe that may be benefit the services, how many people are actually accessing services? That's what the term penetrance are used. I also wanted to put a caveat here that not, even though there might be some folks that have a SMI, serious mental illness diagnosis, that the current design of Medi-Cal, the bifurcated system, is that just because you have a serious mental illness diagnosis, that doesn't mean that your services has to be at the county level. So the state has been very clear that if someone is stable, let's say that someone has a bipolar disorder, but the diagnosis is well managed, the person is actually, maybe very stable, has a job, and all they need is to be able to continue to see a psychiatrist or therapist on a regular basis, that service can be delivered through our managed care system. So that's really where there's a little bit of a disclaimer here.
Well, and Edwin, that could also be presumably somebody like that could be managed through Kaiser or whatever.
Correct.
Whatever their medical insurance is.
Yes, absolutely, yes.
What I'm trying to, based on that number, what I'm trying to understand is how many people fall within our purview that aren't covered by somebody else that need our services. And what I'm really trying to understand is, as I look out at, in particular, homeless population, with the percentage of them that have serious mental illness, diagnosed or undiagnosed, that don't necessarily have placement. And as we're looking at subacute, acute, and all of these other facilities, how are we marrying what I can visually see on the street, doing the analysis, and marrying the goals that we're trying to set in terms of services available?
Sherry, do you want to speak to that one? That's more of a system-wide level question.
Yeah, just, I think referring back to some of the information that we shared earlier in the year during the initial workshop, just as a reminder, that we share this publicly, both with the board. We reported that in 2021, we served 31,449 clients in our behavioral health system. That included 9,000 children, 5,500 youth and young adults, and 17,000 adults and older adults. So in general, that's, the number of individual Medi-Cal beneficiaries and uninsured individuals that we're serving every year. We continue to track on, as Edwin was saying, penetration rates according to the general Medi-Cal population. But in general, this has been about the number of individuals we continue to serve in our public behavioral health system on an annual basis.
So the delta between the people that we're serving and the folks that I can see who are kind of getting ill on the streets, that if we took our point in time count, which I know is not accurate, but if we took that point in time count and we looked at the need, we did an assessment of the need of those folks that are service resistant, or frankly, that we don't have the services available that they need, which I'm presuming that's part of our problem, then we would be looking at growing our system for people who are seriously mentally ill with the continuum of services by what? Do we think that's 6,000, 10,000? What do we think that is?
Supervisor,
I was just gonna, sorry, Key, I was just gonna clarify to make sure that we're answering the question that you're asking, Supervisor. You're saying if we were to identify the number of folks within the cohort of homeless individuals living on the street, how many of those have serious mental illness, where a component of getting them out of that circumstance is ensuring that they receive the behavioral health treatment they need? How would our system grow? Is that the question?
Yes.
Yeah, I mean, I think, Key, I think you're about to pick up on this, but obviously a core component of that strategy is partly why we're braiding together a lot of the work that's being done in the Office of Supportive Housing to combine housing services and the mental health and behavioral and the substance use treatment services that folks who have both homelessness and mental illness and substance use disorder as challenges that are contributing to those circumstances. But Key, did you want to pick up there?
Yeah, I do, but I think Dr. Smith has his hand.
Dr. Smith.
First of all, a lot of the people that are currently on the street are counted in the 32,000 because they do get services, and the 32,000 is unduplicated individuals who get services through the county. I'm not aware that we can predict exactly the answer to your question, but I would say at least another 10,000 individuals, unduplicated individuals. But Key maybe has a better answer than I do.
Key, you're muted.
Yes, Dr. Smith, I don't have a sort of a great estimate. I was just going to say that I think I'm trying to, I think we understand sort of the question that you're asking, which is sort of there is a prevalence rate that the state gives us for serious mental illness. From that, there's an estimate of sort of maybe how many Medi-Cal beneficiaries there are, how many we're serving and how many we should be serving. And then there are people who are homeless, who all have histories of homelessness, who may be receiving some services, but perhaps not fully engaged. And we have to sort of factor those individuals in, and then try to have some estimate of sort of people who are not engaged at all. And trying to figure out sort of those estimates is something that would be challenging, but we can take a look at that if that's something the board wants us to do.
Yeah, and Key, and I'll just say this to my colleagues, I don't think we know the system we're trying to build out without knowing those numbers. And I think that we do have a tool, and I always say the name wrong, Key, I always say VDAT. I know, I don't know why I always say it wrong, but that tool has a lot of information in it that I think. One question I have is whether or not we can marry that to the health records that we have to determine the utilization and the need. And I do know that the state's number is slightly higher than the one that Dr. Smith gave us. I think the reason for that is that they're using an average that may or may not be applicable. It's hard. It really is hard to know that. They gave a number, I think around, well, actually it was a percentage of our homeless population that needed access to care court as an example. But I actually think that if we don't understand this number, I don't know what we're building toward. And I think then we're only building toward whatever the national standards are, and those are fine, but they may or may not match what we actually need locally. So I do want to just say to my colleagues, I recommend that when we're looking at and doing an analysis of homelessness, which we're on an ongoing basis doing, that we have to take a look at those records and determine whether or not we are providing support and help to those in need, and frankly, to be able to assess what kind of housing do they need. How many people do we have, for example, that are failing out of the current housing? We know those numbers now. What kind of services do they need to stay housed? Because we are deep enough into the community that we should know that. And I think that would help us all quite a lot, and help us, and at least help me stop chasing you all for the question about this continuum. What part do we build out? How big are the waiting lines? Like we need to be able to answer the question about who's in our service venue, our service purview, and what are we responsible for? What are private insurers taking on? And I know it won't be an exact number, but it will be really helpful. So I am recommending that we do that body of work. Just a couple of other things that I wanted to say to the staff, and I really am excited to see all the movement on residential beds. That's just a tremendous amount of work. Thank you for getting that done. I am really interested in our partnership with San Jose Behavioral Health, since they're on property that we own. And one request that I would have, is you could do this off agenda, is could you send out the agreement that we have with them? I'm curious about how long we're going to be in partnership with them on the land they're building on, because frankly, if they're not assisting us and they are on our property, we should really be thinking about restructuring our contract with them and the method for doing that. So if you could send that out to the board, I think it would be great. And then I also just want to say, I really hope we continue to include the people that are referred to as unlicensed or independent living. These beds are really, really important, and that you continue to work that through, because those are assets and resources that we need to keep our hands on, or at least our knowledge on. And we have received some information from Lorraine Zeller on this, and the Alameda Grand Jury report that describes group living facilities working group in that county, I think is very, very informative. And then, I have some other comments, but I want to be respectful of everybody's time and just say that, I love that we're doing this once a month. I really want to say to the staff, when you come here and you're feeling the pressure from me, it's really because of the people that I see on the street that you're feeling my anxiety. But the direction that you're moving in and the work that you've been doing over the last year, it's moving in the right direction. So I really do want to say a very sincere thank you. And my push isn't out of disrespect for you. It's out of, honest to God, just the pain and suffering that I'm seeing on the streets of the community that I represent. So that's what you're hearing from me. But thank you all very, very much. This was very informative.
Thank you. I'm going to make a quick 60-second comment. I'll go back to Supervisor Lee, then we'll hear from Vice President Ellenberg, and then hopefully we can move on. The services that the county provides, I would say for the most part, the supply of what we can and do provide is less than the demand that's out there. It's just the nature of what we do, taking care of the people we do, whether it's providing more parks, more libraries, more housing, more services, more medical services, more neonatal beds, whatever it is. I often say the county does God's work And there is not enough supply of our services to handle the demand. But that doesn't stop each and every person in this county from doing the very best they can, and from this board and administration and everything else from doing all they can to improve and expand the services we provide in every area. The last couple of hours have been about this topic, extremely important topic. But we need more fire services. We need more we need more of a lot of things. And I just applaud all the people, Greta, Sherry, I don't know, there must have been about a dozen people speaking today in your monthly presentation. And I applaud all of you for your passion that you care about this subject that is so important. And I share that feeling with my fellow supervisors. Supervisor Lee, your hand is up anew, correct?
Yes, anew, and I just want to have a follow-up with what Supervisor Chavez just mentioned. And it's something that I think is not only bothering me, but basically everybody who've encountered regarding these most severe SMI, because there's so many category SMI, shall we say, but I'm talking about the most severe category that we've all encountered on the street corners. One, those are most visible on that specific street corners that we all know. Like for one that I know, 7th and Santa Clara by the grocery outlet, there's an individual who talks to himself, sometimes screaming. Some of them don't bathe, and honestly also public health problem to themselves and everywhere they go to. And we know we have these individuals in various parts of our county. And to me, all of them are crying for help. And I would think they would be qualified for Murphy conservatorship and all these programs that we have, or that maybe some of them would refuse services. And I'm not talking about the thousands or even hundreds of people now. We only talk about really probably a dozen or two, a few dozen people we're talking about. Now, I apologize for this if this is a dumb question, Dr. Smith. How do we start with them? I mean, who do I call? And does the county actually track these individuals? Because again, I'm not hundreds, I'm not those few. How are what are we doing to serve them so that they actually have a place to go to, that we're actually doing something for them instead of just let them roam on the streets?
I think I'll leave that to Sherry.
Sure. Thank you for the comments and questions, Supervisor Lee. I think similar to what you've conveyed, I think, the community wants the same thing, care and support for those that are suffering on the street, as Supervisor Chavez referenced as well. So I think, there are many support services and offerings that we have. The board did opt in to AOT last year, and we do have 50 individuals enrolled in that program, who our teams are very actively working with to engage into services, as well as all of the in-home outreach teams, our mobile crisis response teams, and the partnership that we have with Office of Supportive Housing. So really, the intent and opportunity is for us to be able to continue to bring those resources together. Oftentimes, what is really required and what we're learning from our AOT team is that active relationship building, engagement, and outreach in the community. Those, the individuals that our teams are working with recognize, wow, you are coming back time after time. You do care about me. You do care about what's happening to me, what I need. And I think sometimes that sense of trust and relationship building is really one of the most critical factors in the work that we're doing. So I don't know that there's a simple answer or one simple solution. It takes a lot of different efforts and opportunities and relationships and partnerships to do the work that we're doing. So my apologies, I don't have a simple answer, but really the efforts that we are doing collectively together to build the beds in housing, to build the treatment teams that are on the streets, partnering with the city of San Jose where we can to ensure that individuals in the city of San Jose are being supported are all of the efforts that we're doing collectively.
So no, no apologies. This is not a simple question. Clearly, Sherry, and this is clearly one of the most difficult issue we're dealing with, and we are certainly making huge progress, right, on this AOT or Laura's Law, some call it. And I first of all want to thank you for the implementation for the past year of how much work has been done on that. Now, regarding the simple question, as this individual I mentioned, this type of a situation, would it be the trust team that I call? Would it be 988 that will make the phone call to ask someone to be sent to help this individual? Is that where I would start? Not me as a supervisor, but me as a common citizen. If I see this type of situation, people on the streets that needs help, clearly, is that who I would call?
Yes, I mean, certainly our 988 number is an opportunity to call, and you will be connected with one of our support counselors who, one, can either provide support via phone, or if there's a need to have one of our teams deployed, depending on the circumstance, that opportunity is available. Of course, we've shared related to 988 that if you are having a different area code than 408 or 669, it's best to call our 800 number to gain access. But yes, that would be a very good place to start.
Okay, all right, I'll get the word out. I just want to make sure that the word's out to the public that this is the resources of how people need to turn to. We don't need to call 911. There's not a crime being committed as much as just somebody who's screaming for help by their action and being there. Thank you.
Thank you. Vice President Ellenberg.
Looking for the unmute. Thank you very much. I am aware that this presentation and conversation are taking a very long time, and what I would say about that is actually filling my heart is that it is clear that this is a shared priority and a shared urgency of our board. And I too, like my colleagues, am deeply appreciative of all of the staff for the tremendous work that you're doing, for the time that you're taking to put together these very detailed and substantive reports for us, for helping us to understand the deep complexities of all of this work. So I want to start with some gratitude before, like my colleagues, I dive into a few areas where, of course, I'm looking for us to be continuing to move forward with every aspect of urgency, every drop of urgency we can. Let me start with two specific questions and then some broader comments. In follow-up to Supervisors Lee and Chavez on medical detox, if the direction to the public is to go to the emergency department to access the service, and it sounds like we're clear on that now, do we have trained addiction medicine providers on staff 24/7 at our 3 emergency departments to provide the support when people present for care? That might be a Paul question. Hi, Paul.
Hi, thank you, Supervisor. So we work very closely with the Behavioral Health Department. They do have assigned specialists to support our medical team in the emergency room here at Valley. I would have to review to see what type of services we have at O'Connor and St. Louis, but I know we work very closely, specifically here at Valley Medical Center, in large part. I'm sorry. In large part because many of the individuals that service providers are engaged with in terms of their clients know that the VMC emergency room is the place where they would get the most support relative to their needs.
And we are talking about specifically trained addiction medicine providers.
Yes, and Edwin Poon, maybe you can speak to the type of staff that we partner with.
Yeah, I think we have supports that we provide both at the EPS, but also at our ED to support any consultations and necessary needs. But I also wanted to emphasize that with medical detox, a main key component of medical detox is really about, of course, obviously the medical piece of that. And I mean, Paul, I don't want to speak out of, sort of term or in terms of scope, but I would imagine that any emergency doc would also have that capability of really assessing someone for their physiological need, I mean, for medical needs when it comes to severe withdrawal symptoms that are physiological in nature that require medical attention. So I would imagine that would be a setup that the ED would be capable of handling.
And that's
So,
correct.
Edwin and Paul, I appreciate that. I know that we have a number of addiction medicine specialists. So I think what I'd like to do outside of this meeting is perhaps gather several of them and invite you both for a conversation with our specialists to really get an understanding of whether we are doing all that we can for folks that come in for medical detox, or whether there is some more specific or higher level of care. I'm hearing concerns, but I'm absolutely not in a position to be making that determination. So I hope you'll welcome an opportunity to have that conversation.
Yes.
Thank you so much. On slide 32, Appendix C, the 7th item on the list, I'm going to tell you what it is, so don't worry if you can't find it right away. It's the rate adjustment for the substance use treatment providers, which is listed as TBD, while the mental health providers rate adjustments are complete. It was my understanding that the rate adjustment for the SUTS providers is going to be part of the mid-year adjustment. Is that correct? Is that still on track?
Supervisor Ellenberg, thank you for your question. Yes, we are still working on analyzing the data and working with our providers, and are on track for mid-year.
Thank you so much. I appreciate that, Sherry. And then just shifting to some broad comments, again, not in the spirit of critiquing any of the work, but just looking to see how much farther we can get together. It's been 11 months since Supervisor Lee and I addressed our referral to declare public health crises in mental health and substance use disorders in our county. And in that time, I believe, and Supervisor Lee said as much, that we've made good progress, clarifying the challenges in our system of care, adding services, and growing the workforce of clinicians and key staff. And I am deeply, deeply appreciative of this work by not only staff in behavioral health, but across our county organization. I still have some anxiety about the pace of our progress. We all acknowledge that this is an emergency. The memo that Supervisor Lee and I introduced in August was intended to spur specific action by the CEO on items already funded and within our control to implement. 3 of those 10 items are complete. Thank you, thank you. The others are in various stages of progress, and I want again to press for urgency in addressing the remaining items, particularly those that relate to building treatment beds. Most critical, and back to the original referral last January, is starting with a strategic and clear vision for where we go. To that end, I particularly appreciate the comments and questions raised by Supervisor Chavez today. Slide 5 today noted additions of some beds in some levels of care. What I'd like to see in reports going forward is that this slide should match up with the targets previously submitted that add up to the 500 additional beds in the system of care by 2025, assuming, of course, that this is the right goal to meet the need in the community. But whatever the numbers should be for both the board and the public in general, we should be able to see, number 1, the connection between the goal and our progress to date. And 2, we should be able to distinguish where beds are truly additive to the system, as was noted earlier today, and where we are representing beds that were already planned or that we're in fact scooping up from our regional neighbors. That's what I'm looking for there. Earlier, Key shared on slide 8 several new strategies for adding supported shelter. Thank you for that, Key. You emphasized the temporary nature of these beds, though, and I think distinct from this category of care, crisis residential beds have a 30-day limit. Could you just elaborate on what you consider temporary for supported shelter?
Sure. I think in years past, we had shelters that were sort of day by day. I think now, especially for behavioral health clients, we have a sort of an indefinite number of days because the goal is to really, find them permanent housing. I think we have sort of goals, check-in periods like 90 days, 6 months, etc. But if people still need that shelter and there is a path to housing, or people working on a path to housing, there's sort of no hard time limit. Yeah.
Thanks. Is board and care considered supported shelter or residential care facility under the permanent supportive housing banner that was on slide 14?
Sure. Thank you for the question. So residential care facilities, we use that term to mean facilities that are licensed by the California Department of Social Services to provide people with assistance with activities of daily living. And I think when we use the term board and care, it's sort of a form of shared housing with some supportive services that are not licensed. Typically, both of these types of facilities are kind of similar in that they're single family homes. So I think when it comes to the challenge, of course, supervisors, that both types of facilities can be used for either both temporary or permanent. And so what we try to focus on in our presentation is sort of what are the permanent housing strategies, which include residential care facilities, which will include and do include sort of board and cares. For example, something we call the Bluebell House, which is a house that we own. Maycom actually provides the services. People live there temporarily. It's not licensed, but it's a home people share. People stay there indefinitely. They have a lease, they pay rent. And then, so we have a permanent housing strategy, some of which includes the establishment or the expansion of residential care facilities and board and care homes. And on the sort of temporary side, we do sometimes use residential care facilities because people leaving sort of residential treatment facilities or high levels of care need some of that more intense assistance on a temporary basis. And sometimes we use sort of board and care homes as well.
Thanks. I appreciate that. And I know that we've got a later item on the agenda today where we're going to circle back to board and care, but I want to make sure that this level of care is showing up in our planning as we talk about total number of beds and meeting needs going forward, and looking at permanent housing, that this model is called out in our work as well. And when we discuss housing strategies for people with mental illness, including for Project Home Key and the permanent supportive housing, again on slides 8 and 14, can you clarify for me if we are in fact adding new resources to grow the number of beds, or are we carving out a portion of the already planned beds to be dedicated for people with mental illnesses?
Thank you for the question. So on the supported shelter, which we mentioned Home Key, there are some projects that are already in operation for which we hope to carve out some beds. And there are 2 projects that are sort of still in the process or under construction or under development. So those are new adds, although all of the Home Key projects are new adds to the system overall. Does that answer your specific question?
Well, they were new before we talked about using them for people with mental illnesses. So do we have additional beds, or of the new beds, are we now deciding that some will be held specifically for people with mental illness? That's what I'm trying to.
Yeah, so for the 3 projects that have been awarded, I guess from your vantage point, it would be sort of carving out sort of already awarded or planned beds. And then, as we mentioned in sort of the last section, is we're working on 3 or several potential new sites, Home Key sites that would add further to the supported shelter system, and some of those beds we hope to use for this target population.
Great. I realize that we're trying hard to make sure that this isn't a shell game, and that I don't mean that was a derisive term. I don't mean that, but that we really are expanding the entire ecosystem rather than moving people around, because of course any beds that we carve out for people with illnesses are then not available for people who are unhoused and have other struggles but not mental illness. And to Supervisor Wasserman's point, we never have enough money, resources, time, or people to do every single thing that we want to do. But I appreciate the thoughtfulness in moving forward here. I'm going to wrap up with some direction, and I'll make it a motion and hope for a second so that we know where we're going moving forward. Adding capacity for treatment and housing and being transparent, again, on what is additive across the region, I think really needs to be a focus of our response to the crisis. Of course, we need to provide more care up and down the continuum. And to do that, we need facilities and we need the workforce in those settings to deliver the services. So consistent with the analysis on the need that Supervisor Chavez raised, this ties in with the planned report on system performance indicators. And as these questions, I think, are converging, I'd like to see a few key elements addressed in our planning going forward. First, that we start with a clear picture of the need, of the scope of the need. Second, that our strategic goals have meaningful outcome indicators associated with them, not just process or interim indicators. Third, that we prepare to use these metrics to connect our strategies to our investment of resources to move the needle where we know we have gaps. And fourth, that we focus on how we communicate to the public in clear terms our goals and our progress, and avoid mixing in elements that borrow beds from other service types or neighbors, so that we're able to show what's truly additive in our regional system of care. So that's what I'm looking for in the next report going forward, and I would ask for a second.
I'm happy to second it.
Thank you.
Okay. Thank you. We have the motion. We have the second. Roll call vote, please, Dave.
Actually, just Mike.
Yes, Supervisor Chavez.
Sorry, Mike. I just want to make sure that's inclusive of other requests that were made during this discussion, including how do we actually know how many beds we need, like that number, that analysis from the illness perspective and who we have in our community is really important.
Absolutely. And I was sure to incorporate that by noting at the top. The first one is that we start with a clear picture of the need, but I'll explicitly affirm that it includes your direction. Yes.
Thank you. Dave, roll call.
Supervisor Lee.
Aye.
Supervisor Chavez.
Yes.
Supervisor Simidian. We'll come back. Vice President Ellenberg.
Yes.
President Wasserman.
Yes.
And one more time for Supervisor Simidian.
Sorry for being slow on the draw. Aye.
Thank you.
Thank you. 16 was handled in consent. We're going to move on to 17. And members, if you're okay, I'm just going to try and find some time where we can. On this item 17, Sherry, I consider it a no-brainer. I'm happy to make the motion to ratify the grant application for the community service infrastructure. And ask for a second. Thank you, Supervisor Lee. We have no speakers. Supervisors, any comments, or we'll take a vote? Vice President Ellenberg.
Sorry, that was very quick. And I just need, I did have questions. If you can give me 5 seconds to take a quick look down and see if
take money.
Any of them can be. Goodness. This is item 17.
Yes.
Sorry, we did go very quickly here. Yeah, what I will offer here, rather than going through my questions, is just to request, and my staff can review this offline with the relevant departments to save our time here. But what I'm interested in is a more comprehensive strategy in our February monthly report on the behavioral health crisis that will show us the target on residential homes that would be needed in the system of care, identify existing resources that could fund the need, outline criteria for the selection of homes and locations, and resources for effective communication with neighbors. Again, it's connected to the previous item, and just want to make sure that we're continuing that focus. And if that's clear without any questions, then I don't need to add anything else.
Thank you. So we have that direction as well. And the motion is to ratify the grant application to get you some more money, Sherry. Dave, roll call vote, please.
Supervisor Lee.
Aye.
Supervisor Chavez,
Yes.
Supervisor Simitian.
Aye.
Vice President Ellenberg,
Yes.
and President Wasserman.
Yes.
Thank you.
Thank you. Item number 19, Dr. Cody, and this is under advisement from the August meeting. Receive report from the Public Health Department relating to prioritizing and funding recommendations resulting from the public cost of gun violence study. And Dr. Cody, thank you and your department for putting out the staff report ahead of time, allowing us to absorb it. Do you have any additional comments you wish to make? Supervisor Chavez, your hand is raised.
Thank you. Yes, this is in response to a referral that I made, so I was just gonna give some input. All right. First of all, I just want to say thank you to the staff for coming back to us with these strategies. And I'm really excited that the board is taking a leadership role in this. The staff report is really strategizes on how to make investments. I want to say, I want to make a motion to move forward with this with two requests. Request number one is that the staff have a discussion with the Office of Gender-Based Violence to look at where there may be opportunities for overlapping approaches as it relates to violence in the home and domestic violence. I think could be helpful. And then the other issue that I wanted to raise is how and to ask staff as they come back with further strategies to come up with how we have a violence prevention program that's integrated so that we don't have violence in this regard, gun violence and domestic violence, but really have that underpinning of violence prevention. And I see that we're doing that from some place-based strategies, but want to better see an integration, as I am certain we're going to have more constrained resources in the future. And I'm nervous about programs being pitted against each other instead of being integrated now.
Thank you for bringing this to us, and thank you for your motion as well. Do I have a second to the supervisor's motion?
I'll second.
Supervisor Lee, thank you. Supervisor Chavez, any other comments? Otherwise, I'll go to Supervisor Lee.
Thank you.
Oh, Supervisor Lee.
Hey, thank you so much. First of all, thank you so much for the comprehensive report regarding the funding priorities, public cost for this gun violence study. I really am glad to see what we're working on, and certainly there's so much more we can do as well. Along with that, I just want to do a PSA regarding the South County gun buyback this coming Saturday on December 10th at 9 a.m. at the Morgan Hill Outdoor Sports Center, sponsored by our own President Wasserman
and Supervisor Lee.
Yes, we're working on this together. And really, it really is a small investment of placing some small amount of money here to provide these additional these gun buyback. We had one in Milpitas in May, and we're doing this again. So it's twice this year. One in the north east of the county, and then the south part of the county. And I certainly do think that in the future we should make this a periodic event. So at least one, if not two, gun buyback a year. Really is a small effort to removing unwanted, unneeded guns from our community to reduce these type of gun violence we talked about.
Thank you.
And I do think that the funds should come from general funds and not from necessarily just a DA's office, which they're so generous. But I think we really should be able to do that. And I would like to certainly have this come back during the budget hearing later on. Thank you.
Great, I agree. Thank you. Vice President Ellenberg.
Thank you so much. Thank you to staff for the report and to Supervisor Chavez for bringing this referral forward. I particularly appreciated in this report the thoughtful approach that staff is taking to the work. And I want to really emphasize the importance of tailoring the strategies to each of the 9 priority zip codes. 95117 in District 4 is a pocket of high need, disconnected from other resources. So tailored strategies with meetings in that neighborhood is going to be critical to a successful partnership. I'd like to offer direction to proceed with the funds proposed as part of the mid-year budget. And if additional resources are needed, Supervisor Lee just alluded to please bring a recommendation forward during the annual budget process. Not only on the gun issue, but to fund the engagement of local cities and priority neighborhoods. I'd like also to see in the budget funds for translation services and childcare during the times of the meetings. With regard to translation, I would recommend that we proceed immediately with translating the gun study report and a one-page infographic summary beginning in Spanish, given the disproportionate impact shown in the report on the Latinx population, so that the materials can be broadly distributed and understood in those 9 priority zip codes. And finally, I would be interested in a progress report on implementation at PSJC in August, which would be 6 months after the mid-year funding, and should allow for an update to the work plan submitted with many of the deliverables that are scheduled through June. So that would be
Member, motion maker Chavez, seconder Lee. Are you okay with those?
Forgot there was a motion. Thank you.
Yeah, I would. I'm happy to accept that. The only addition I would make is that at the time it's going to public safety and justice, concurrently it should go to children's, family, seniors, and in part because of the community-based organizing and the violence prevention work that's going through that committee.
There we go.
Yeah, thank you.
Okay.
Thank you very much. Apologies for not realizing that there was already a motion.
No worries whatsoever. Dave, no speakers. Roll call vote, please.
Supervisor Lee.
Aye.
Supervisor Chavez.
Yes.
Supervisor Simidian.
Right.
Vice President Ellenberg.
Yes.
President Wasserman.
Yes.
Thank you.
Thank you. That was item number 19. I'm going to go to 20. We have Consuelo here to answer questions regarding her report. Supervisor Lee, do you want to open this up? This is receiving a report from the office, so there's no motion necessary. Did you have anything you wish to add?
Yeah, well, first of all, I do want to thank Consuelo and her team for the hard work on this comprehensive report. I very much appreciate your continued collaboration with City of Sunnyvale to try and find solutions to get people to stay warm in these cold winter conditions. It's been brought to my attention that the City of San Jose is also working with Home First to operate 2 overnight warming locations, one over at the Roosevelt Community Center and the other one is located at the West Valley Branch Library. And that these locations are open on a nightly basis by referral only from November to April. The way it was explained to me and my team is that there's been considerable logistical and operational challenges to operate an overnight warming center using a pop-up type of approach, and that Sunnyvale has expected these shelters to house only local Sunnyvale residents, and they would only be activated when it's inclement weather episode. So whether it's going to be open on an overnight basis and open daily like the one San Jose and Home First are doing right now. So I just want to make sure, is my understanding correct here, Consuelo?
Thank you, Supervisor, for the question. The only thing I would add is that there are daytime warming locations that are open. And thanks to our partnership with the Office of Emergency Management, they manage a website on the county's general page that allows people to identify where those locations are, in addition to the 3 hotlines that are available to folks who are seeking shelter from the inclement weather episodes.
Right. And what I've been told is that there are issues regarding potential, providers not very excited with the pop-up approach. So is there a way you could help highlight the difference between what the San Jose is doing with Home First along with what Sunnyvale is proposing right here?
Absolutely, Supervisor. And the model that the City of San Jose is using is very similar to the work that we are doing in the City of Mountain View at a local congregation, where essentially we have a contract for the entire cold weather period, starting in mid-November through the end of March. That allows the provider to anticipate and know that they have to run the shelter overnight for that period of time. That certainty allows them to hire staff or shift staff around so that there's coverage. What the City of Sunnyvale is proposing is to only have and activate the shelter when there is an inclement weather episode. Because we don't and can't predict the weather, it makes it very hard for a provider that is already struggling with staffing issues to then pool staff to basically work overnight. So if you can imagine, they're working during the day, now they have to do an overnight shift. And you'd be running this 1 day 2 setup operate it for 5 days, and then have another day to break it down, only to have it operate for a week. That makes it very hard to project cost, to project usability from an end user's perspective. We are not necessarily seeing any takers for that style of programming, if you will.
Okay, so my concern here is, obviously we're getting cold now, and then we really can't dawdle too much longer before people potentially will suffer. So what I would like to do is this. I would actually like to ask the administration to move forward with the request for proposal process for a pop-up shelter approach model. But in parallel with that effort, I'm also requesting that the administration proceeds with a separate request for proposal process for winter shelter that's open on a daily basis, similar to the one that San Jose is doing with Home First at the locations. If the city council and lift experience advisory boards that you're able to engage with or things that this is a good or better idea. What I would like to do is I really think we need to move quickly to explore any and all avenues that we could take. If one approach is more interested parties than the other, that the needs to be made clear. Because what I really want at the end of the day is that people need to stay warm and not die from freezing this cold weather, and that we need to move forward and not just be waiting around for more reports. And so that would be my motion.
Thank you for that motion. Do I have a second?
Yes, Cindy.
Thank you. Supervisor Chavez, a second. Dave, if you'll please turn to our speaker.
Certainly. One moment, please. And that person has put their hand down, so we have no speakers.
Okay.
It's back up. There it is. My apologies. It's back up. Sorry.
No
Rose Gregorio, looks like we will not be able to unmute Rose because they are using an older version of Zoom. You are welcome to send an email to the board operations email address if you have comments you would like to submit in writing, or you can try upgrading to a different version of Zoom and we can try again later.
Thank you. And we'll go, we have Vice President Ellenberg with her hand raised.
Dave, could you say the email address, please, for anyone that needs that?
Yes, the email address is board operations, all one word, at cob.sccgov.org. Again, that's board operations at cob.sccgov.org.
Thank you.
Thank you.
Thank you, Vice President. All right, Dave, roll call vote for item number 20.
Supervisor Lee.
Aye.
Supervisor Chavez.
Yes.
Supervisor Simidian.
Aye.
Vice President Ellenberg.
Yes.
President Wasserman.
Yes, as well. Thank you. That item passes. 21 was handled before lunch. We now move on to item number 22. We have a 100 and some page report. We have Acting Sheriff Kenneth Bender here for us. And I'm going to turn to Supervisor Simidian with any questions you may have. I'm sorry, I meant Bender. Thank you.
Oh, thank you, President Wasserman and honorable members of the board. I'm here today, and so is Director of Procurement, Jean Clark, to provide some high-level overview information points that was included in the board packet that you received. And then after that, we'll be available to take questions. We'll have a few subject matter experts here to help with that as well. So this is a request to the Board of Supervisors for the county to continue its Axon contract for body-worn cameras, advanced feature upgrades, and limited data storage for the next 5 years. The contract does not include tasers, which could potentially come before the board no earlier than February of next year per prior board discussion. Oakland has received this contract and item and provided their report as well, which is attached. They confirm that the tasers are not included in the contract before you, and that the additional features of the upgrades and enhancements do not trigger the surveillance ordinance, as well as what County Council had discussed in the last board meeting for the item. And then finally, Oakland also evaluated the increased costs, and they provided their analysis in their report as well. And they noted that the upgrades should bring efficiency and automation to the current body-worn camera program. The county's privacy office also reviewed this item, and they indicated that they don't have any privacy concerns moving forward. And there is a representative here from their office if the board has any questions of them. It's important to note that this contract seamlessly integrates the body-worn camera, current body-worn camera program with the Sheriff's Office dash camera system on our patrol cars. And that's important because it ensures that body-worn cameras are on anytime there's an enforcement action made on a vehicle stop. So the system automatically connects via Bluetooth and turns the cameras on, which is good for important for good quality control as well as accountability for the actions. So this contract is all inclusive for hardware and software upgrades throughout the life of the cycle of the contract, which is for 5 years. And I will pass it off to County Procurement Director, Mr. Gene Clark, who will touch on the actual costs and numbers of the item, and then we will be available for questions afterwards.
Thank you. And Mr. Clark, we have the report before us, so any high-level summary you wish to give is welcome.
All right. Thank you very much. Thank you, Sheriff. Good afternoon / early evening, board members. Gene Clark, Chief Procurement Officer. And I do want to highlight the fact that we had a $4.4 million cost savings, cost avoidance. We track both. We did that through the bundling of the agreement aggressively. I'll break that out in the 22 cost summary briefly. But if worded differently, if we were to go a la carte, we would have paid $4.4 million. So the bundling was an aggressive negotiation. In 2016, we really started with the cameras at the basic level. We made a couple orders there, 4.4 million, 1.7, then an additional 2.3 million that got us to the 8 million. That was a question we had. How did we get that 8 million? We broke that out. And then moving forward to 2022, we've got the inclusive program upgrades, as the sheriff indicated. It equates to 1,275 cameras. That equals a times the 198 per officer per month. And what we got there in negotiations was 15% discount in bundling it and an additional 5% discount to bring us at 15.8 million. We rounded that to 16 million. That's how you get the 16 in the ledge file. And then I would make a couple brief comments about competition. Procurement is happy to continue to pulse that environment. Motorola is one of the bigger players in that area. But with all these features, the department feels it's in the best interest to go with Axon right now, but we can continue to pulse that and report back if the board so wishes. So I will stop there. We had a lot of information that was indicated in the packet and are available to answer questions. Thank you.
Thank you very much. Dave, let's go to our speaker.
Certainly. One moment, please. Next speaker is Irvish. I'm unmuting you. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Thank you very much, Board of Supervisors, as well as the respective county staff and the Sheriff's Office as well. I think it is important to, whenever there's a technology and as well as any new advanced technology inclusion that is to be made, it is always important to make sure that the inclusion is being part in alliance with the corrections and the law that is being abided by the universally and the uniform standards. In terms of a technology, whereas the evidence-based management system is being incorporated, it is very important to make sure that how it is being budgeted out, what is the appropriate criteria that is to be defined to acquire the technology, and if there is appropriate need for it, then what is the compliance and as well as the standards, and as well as what are the different accounting authorization and the approval process that is to be in place such that the authorization be made only in terms of a requirement of a technology, not when any contingency is to be arrived. Such kind of a technologies are nowadays is a very commonplace being used by the sheriff as well as being used by the police department. However, it becomes even more important that And what is a procurement is a part of a legality that approves the use of the technology, and how the law that changes the criteria for such as well. For example, in terms of evidence-based management system, even most of the mobile devices, they also have a face recognition software as well. With this particular evidence management system, whether particularly spending an amount of $1 million or maybe more than that, whether that suffice the reason for the technology's procurement or not. We are already in advanced stage. So we wanted to make sure that the amount of money that we spend is also satiates the requirement and the criteria as well. Thank you.
And that concludes our speakers.
Thank you very much, Dave. With that, A and B are to receive. We'll consider it received. C and D are recommendations. I'll make the motion for both C and D as they are written on package page 125. C is approving the agreement with Axon Enterprises, and D approving the request for appropriation modification number 80. With that, I'll make that motion and look for a second, and then open it up to any supervisors who wish to make any comments. Do I have a second? Thank you, Supervisor Lee. Supervisor Simidian, you have a question? Do you have a comment?
A couple. My first question is there anyone from OIR Group, our OCLEM folks, the Office of Correctional Law Enforcement Monitoring, in the meeting with us today?
Yes, Michael's right there.
All right. Mr. Janako, any chance you can show yourself to the assembled multitudes here?
He's there.
All right. And I just want to say I wanted to say I was very pleased to receive the 10-page report from OIR Group, our Office of Correctional Law Enforcement Monitoring. I thought it was a model of clarity. I thought it addressed the questions that were raised at our prior meeting quite clearly. And Mr. Janako, I see that the memo comes to us from both you and presumably your colleague. Is it Teresa Magula? Am I pronouncing the name more or less correctly?
You've got it, sir.
All right. Well, I hope you will share with your colleague the high regard in which the report was held, at least by this supervisor, and how helpful it was in unpacking a lot of issues that frankly were, for me, unresolved after our last meeting. And then I will pivot, Mr. Chair, to say that to the Sheriff's Department, I did appreciate the fact that there was an effort to respond more fully with additional information from the last meeting. I think, candidly, I think the report from OIR Group and OCLEM is proof positive that the Sheriff's Department would be well advised in the future to engage them on these items, because as representatives of the board, they are in a position to say, well, here are the half dozen questions you're going to get from the board, or that we, meaning OCLEM, will raise on their behalf. I just think it is going to save everybody a lot of painful back and forth if we can just anticipate and make that process routine. I know that's with the new sheriff when he arrives, but that would be my exhortation and encouragement. I think that being said, I appreciate Mr. Clark's comments about my words, not his, keeping an eye on the pricing structure here. I think it's pretty clear that Axon sort of engaged our interest, our attention, and our money with a relatively modest, more reasonably priced package when we first went down this path, and has since taken the opportunity both to push the price up, given that they have some market dominance, and also to show us all the many, many features they think that we can't or shouldn't live without. So I will just say I want to encourage procurement to keep an eye out for other folks, and I may well not be here when the time comes, but I would even be prepared to use another vendor just to keep some market competitiveness, in the mix, rather than let somebody gain enough dominance in the area that we really don't have any choice except to say yes, no matter what the number is. I did think it was helpful, Mr. Janako and Oakland folk, that was pretty clear to me. All right, here's what the extra costs really are for. And Mr. Janako and or your team, on page 2 of the report, packet page 131, for those of us working from a packet, there's an indication that about 5.5 million of this is really cost for new features that have been requested by the department, as well as some additional hardware and licenses, and new contract fee and taxes. Mr. Janako, I read the report, as I said. I just want to be on the record. It is your conclusion, understanding that this is a judgment call and that the sheriff's department rendered their judgment, that this is not an unreasonable acquisition, and that the price bears some reasonable relationship to the value added or utility of these upgrades. Is that a fair summary or no? Because if not, I want to probe further.
It is a fair summary, sir.
All right. Then I'm noting, Mr. Chair, and perhaps I should ask the County Council, Mr. Williams, item D is a 4/5 vote requirement because it's a mid-year appropriation modification. Is that correct?
Yep, James, or
Yes, it's a 4/5 because it's a out of budget appropriation from the contingency reserve, and under state law, any appropriation from contingency is a 4/5 vote.
All right. Well, I'm going to be an I vote. As I mentioned the last time, I brought this issue of body worns to our board, back in, I think, December of 2014. So, I'm pleased that they have proven their utility, not just to the community, but also to the folks in the sheriff's department. I'm unenthusiastic about the price escalation. I'll let it go at that. And the last thing I'll say is I really would hope we could get this kind of clarity the first time out, rather than have to go through both this meeting and last meeting. And I'm guessing that's one area where the sheriff's department and I can agree on this one. So thank you for that.
there we go. All right, Dave, roll call vote, please.
Supervisor Lee.
Aye.
Supervisor Chavez.
Aye.
Supervisor Simidian.
Aye.
Vice President Ellenberg.
Yes.
President Wasserman.
Yes.
Thank you.
David, I need your help. Do we still need to do 24, or was that a Vice President Ellenberg consent item?
24 is still on the schedule, Mr. President.
Okay, let's hit 24. And David, you agree that's the last one?
I do agree.
Thank you. I'm going to flip my binder over to 24 as Vice President Ellenberg scrolls through her pages, not using any paper. And I go on to item number 24. I'm sorry, Supervisor Simidian, your hand is raised.
Thank you. I have one question, and then I'm hopeful that I'll be able to offer a motion, Mr. Chair. Do we have somebody here who is presenting on this item to whom a question could be addressed?
I know we have Greta here, and is Imre still available?
Looking to see if Imre is still in the room.
Yes, I'm here.
Yes.
Good afternoon.
Thank you. Thank you both. I've read the materials carefully. I'm looking at page 2 of 5 for the countywide surveillance use policy for the email marketing software. This is packet page 283 for those who are using packet pages. And it is section 2, authorized and prohibited uses. And there was some unusual language, and I just wanted to ask what it's about. It says, additionally, I'm looking at the very sort of second to last sentence, I guess, of section 2, page 2, packet page 283. Additionally, the EMS data showing whether an employee opened an EMS delivered email to their county email account shall not be the sole basis for disciplinary action. What is that about?
Mr. Kawhi? I need a COO or a CIO to respond.
Supervisor, it's Rob Coelho. I may be able to give some guidance. Assistant County Counsel Rob Coelho.
Yes.
The rationale, as I understand it, behind the language, which we approved as to form and legality, is that the mere fact that someone
Excuse me,
doesn't.
Mr. Coelho, I apologize for the interruption. Approved as to form and legality does not necessarily mean it's a good idea. Is that correct?
True.
Okay, so you're telling us that it is acceptable as to form and legality, but it may or may not be an acceptable policy for the board. Yes?
Yes.
All right, I just didn't want that to be misconstrued. Thank you. Sorry for the interruption.
No problem, Supervisor. The clarification is helpful. The intent behind it is to let people know that the mere fact that they didn't open an email is not going to be an exclusive ground for disciplining somebody. We're not firing someone for not opening an email, but to the extent that there's misconduct where they should have opened the email, it certainly can be evidence of the misconduct. The evidence required to start a disciplinary action needs to be more rigorous than a tracking pixel or something indicating someone didn't open an email. There has to be more there than that.
Well, thank you. I'm glad I asked the question because I frankly read it as being almost the opposite of what you just described, which was that someone was worried they'd get in trouble for opening an email that they weren't supposed to, and that the only evidence of that behavior would be the EMS data. And did I clearly draw the wrong inference from the language?
I believe so, Supervisor.
Is there somebody else who might verify this? Because I'm trying
Yes.
to.
The reason for the sentence is so that it's clear that people don't get penalized or disciplined purely because they don't open the email. Doesn't well, it's not related to opening, quote, the wrong email. These are emails that go out to individual email accounts. And so it's not a matter of opening the wrong email. It's a matter of not being disciplined if you don't open your email.
Gotcha.
Any reason you can't bring this back in a week with this language clarified?
No.
Supervisor, would you like to make a motion now to clarify that language?
I'm not getting enough comfort from the two responses that we got that people really are clear what this is and or that it could be amended on the fly. Maybe they are and maybe it could, but I don't want to take that risk. I'll ask that we continue the item to your next meeting. I will make it the Mike Wasserman farewell gift from my office, Supervisor Wasserman.
Thank you.
We'll move to continue the item and direct staff to clarify the intent and circumstances underlying that particular sentence.
Thank you. And if you can find 2 items to put on consent next week, that would be a great offset. Thank you.
Fair enough.
All right, so that one is deferred.
I think we need a second and a vote, Mr. Chair.
I'll be happy. Supervisor Lee seconded your deferral. All right, Dave, roll call vote, please.
Supervisor Lee.
Aye.
Supervisor Chavez.
Yes.
Supervisor Simidian.
Aye.
Vice President Ellenberg.
Yes.
And President Wasserman.
Yes.
Thank
Mr.
you.
Leon, you'll confirm that concludes our business for today.
That is confirmed, sir.
Thank you. We'll meet and do this again next Tuesday at 9:30 on Zoom. Have a good evening. Stay well. Best wishes to all of you.
Thank you, Mr. Chair.
Thank
Take
you.
care. Bye-bye.
Bye-bye.
Recording stopped.
Thank you all for attending. With that, this meeting room will be closed. Have a great evening, everyone.